إنه يحصل لهم daily monitoring لمدة 21 يوم، كل يوم من هذه الفترة هل ظهرت عندكم أعراض ولا ما ظهرت. في حال ظهرت عليهم الأعراض في خلال هذه الفترة يصبحوا حالة مشتبهة. أي مخالط تظهر عليه الأعراض هو suspected case. في المقابل إذا أنهى الفترة 21 يوم بدون ما تظهر عليه الأعراض، خلاص سلموا الله، ربنا سلموا. أما بالنسبة لي البوست اكسبوجر بروتوكول حنتكلم عنه الآن بالتفصيل. طبعا في حال العينة طلعت بوزيتيف يعني يستكمل المريض إجراءات العزل إلى أن طبعا تنتهي الفترة المعدية ويتم علاجه. وإذا كانت نيجاتيف إذن هو حالة يدور الطبيب عن تشخيص آخر. بالنسبة للبوست اكسبوجر بروفيلاكسيس أو اللقاح الموجود عندنا للمونكي بوكس هو اسمه جينوس. هذا اللقاح live non-replicating attenuated vaccine، ويعطى على جرعتين بينهم شهر. لمين؟ بيعطى post exposure prophylaxis وليس pre exposure، ما هو قبل التعرض، باستثناء الناس اللي بيشتغلوا في عزل الفيروس في مختبرات الصحة العامة بشكل عام، هيئة الصحة العامة. لكن حاليا ما يستخدم كبري اكسبوجر، لكن بعد التعرض يمكن استخدامه، وبيتم استخدامه فعلا للممارسين الصحيين اللي عندهم يا إما ميديوم ريسك يا إما هاي ريسك للتعرض. يعني مثلا ما كان واضع البي بي إيز بشكل صحيح، أو تعرض لرذاذ وهو ما كان مستعد إنه هو بالبي بي إيز الصحيحة، هذه نسميها ميديوم ريسك أو هاي ريسك حسب. أما الجنرال بوبيوليشن فقط اللي عندهم هاي ريسك، فمثلا المخالطين المباشرين للمريض في مقر سكنه هذولا مستهدفين باللقاح ويعطى لهم اللقاح. الأفضل دائما إنه يعطى خلال ال4 الأيام الأولى من المخالطة، يمكن تجاوزا إعطائه خلال 14 يوم، ولكن لا يتوقع حالة في هذا الحال إنه يقي تماما من المرض، ولكن ممكن يعمل مودريشن كده ويخلي الأعراض مايلد. هذا بالنسبة لي المونكي بوكس. ننتقل للنقطة الثانية، إيبولا. طبعا إيبولا عشان نكون كده في الصورة، هي تظهر على شكل هيموراجيك فيفر، زيها زي كثير من الأمراض اللي تعتبر في الأخير الكلينيكال بيكتشر حقتها حمى نزفية. النقطة المهمة واللي تفرق عشان وي سسبكت إيبولا هو الإبيديميولوجيكال لينك. الإبيديميولوجيكال لينك هو وجود أو قدوم هذا الشخص من مكان من الدول المحددة إنها هي عندها هاي إيبولا ريسك، أو مخالطته لحالة مشتبهة أو مؤكدة. فيقول لك إنه أول حاجة contact with the case، هذه الكيس قد تكون suspected or confirmed، أو إنه يكون residence or travel to or from an endemic area، أو عنده contact with vector animals. الانيمالز بعضها تعتبر carriers لهذا المرض، بعضها الوايلد animals bats monkeys etc. هذا كله طبعا مصاحب لي clinical criteria. إيش الكلينيكال كرايتيريا المطلوبة؟ درجة حرارة above 38.5 بالإضافة إلى واحد من الأعراض التالية: headache, muscular pain, vomiting, diarrhea, abdominal pain, hemorrhage. خلاص، فهي الكلينيكال بيكتشر اللي هي العادية تبع الهيموراجيك فيفر، لكن الابيديميولوجيكال لينك هنا هو الأهم في الاشتباه. تصبح الحالة مؤكدة لما يصير عندنا laboratory confirmation عن طريق البلاد سامبل التي تؤخذ وترسل طبعا إلى مختبر هيئة الصحة العامة. من هو المخالط في حالة إيبولا؟ هو كل شخص يعيش مع الحالة المشتبهة، الهاوس هولد كونتاكتس، خلال فترة ظهور الأعراض. كذلك اللي يكون عنده دايركت فيزيكال كونتاكت مع البادي اوف ذا كيس، سواء كان هذا البادي live or dead. إذا كان في تواصل مع البلد bodily fluids belongings of a confirmed case، وكذلك الهيلث كير وركرز الكلينرز اللي بيتعاملوا مع السامبلز والبادي فلويدز بدون ما يكونوا مرتدين البي بي إيز. نقطة مهمة نحطها في بالنا: الممارس الصحي الذي يرتدي كامل الأدوات الوقائية البي بي إيز لا يعتبر مخالط، ولا يحتاج، حتى ما يعتبر ميديوم ريسك للمونكي بوكس، ولا يحتاج حتى إنه يحصل على البوست اكسبوجر بروفيلاكسيس إذا كان fully protected بالبي بي إيز. طيب، نظرا لأهمية إيبولا الآن في موسم الحج، عملنا لها 2 operational protocols. البروتوكول الأول يبدأ من عند الاشتباه في حالة إيبولا، سواء كان في المراكز الصحية أو المستشفيات. البروتوكول الثاني ملخص أكثر وبيتكلم عن المخالطين. الآن هذا الإجراء عند اشتباه الحالة في الطوارئ. زي ما قلنا أصلا متى حنشتبه الحالة؟ إذا كان عندنا epidemiological risk factors خلال 21 يوم اللي راحت، هذا المريض كان مقيم في مكان أو عنده كونتاكت أو دايركت هاندلينج لأدوات إيبولا suspected case، بالإضافة إلى وجود الكلينيكال كرايتيريا اللي تكلمنا عنها. هنا مباشرة تصبح هذه الحالة باي ديفينيشن حالة مشتبهة، يتم نقلها بشكل مباشر إلى المستشفى المرجعي. المستشفى المرجعي هي مستشفى النور التخصصي، هي المستشفى التي تعزل فيها حالات إيبولا. يتم النقل عن طريق النقل الإسعافي الخاص بمستشفى النور، ويكون طبعا في كده طريقة معينة للنقل الإسعافي. المريض يكون تحت الكونتاكت والدروبلت بريكوشنز، ما يحتاج قلنا للايربورن ايزوليشن ولا سبيشال هاندلنج لا في المستشفى ولا في خلال النقل، لانه هو unless انه يكون في عندنا aerosol generating procedure. Other than that droplet and contact precautions. يتم اختار الكوميونيكابل ديزيز ادمنستريشن، اداره مكافحه الامراض المعديه بمكه المكرر في اداره تنفيذيه الطب الوقائي بالتجمع الصحي، ويضع المريض طبعا تحت الكونتاكت دروبلت، ويتم البلاغ عن الحاله عن طريق حصن بلس. كل الايكويبمنتس الخاصه بالعنايه بالمريض تكون داخل غرفته بقدر الامكان، ويبدا حصر المخالطين. الكونتاكت تريسنج هو اي شخص خالط هذا المريض خلال ال 21 خلال فتره ظهور الاعراض، ويتم بعد كده متابعه هؤلاء الكونتاكتس لمده 21 يوم، هل بتظهر عليهم اي ساينز او سيمبتومز ولا لا. حنتكلم عنهم ايضا في النقطه الثانيه. طبعا بالنسبه للعزل قلنا ما حيعزل فقط كايربورن لو كان عنده aerosol generating procedure، vomiting، coughing بشكل قوي هذيك الساعه. غير كده هو contact and droplet. هنا في تفصيل للادوات الوقائيه personal protective equipment، single use fluid resistant gown coverall، single use full face shield، disposable face mask، disposable gloves and extended cuffs. في حال كانت هذه موجوده الممارس الصحي is protected ولا يعتبر high risk. بالنسبة طبعا بعد كده تؤخذ العينة في المستشفى المرجعي، تؤخذ العينة، عينة الدم عبارة عن 2 blood samples 4 ml، ترسل إلى طبعا لها سبيشال كده باكجينج وهاندلينج، وترسل إلى مختبر هيئة الصحة العامة عن طريق الكورير اللي هو سمسم، والشخص اللي أخذ العينة يلتزم بارتداء الملابس الوقائية. بالنسبة للمخالطين، المخالطين في حال أنهم كانوا symptomatic وعندهم أعراض، إذن هم by definition suspected case ويعاملوا معاملة suspected case من أول البروتوكول. أما المخالط الذي لا تظهر عليه أي أعراض فيخضع للكارنتين strict quarantine home isolation لكل المخالطين لحالة إيبولا المشتبهة بمجرد الاشتباه وحتى قبل تأكيد الحالة، ويتم متابعتهم لمدة 21 يوم منذ طبعا 21 يوم منذ اللاست كونتاكت تبعهم تحسب هذه الفترة. خلال هذه الفترة لو ظهرت حرارة 38.5 أو أكثر إذن هم هيصبحوا خلاص حالة مشتبهة. other than that ينتهي الكارنتين ويكونوا سليمين ولم يصابوا بالعدوى. كده خلصنا الاثنين الهيفيز. نمر بشكل سريع على أنبضية الأمراض المعدية اللي بتنتشر بشكل كبير في الحج. نبدأ بالميزلز أو الحصبة. طيب اشتباه الحصبة very simple، بمجرد ما يكون عندنا شخص عنده فيفر، حتى مو مرة فيفر 37.5 with rash، تشتبه كحالة حصبة ويتم البلاغ عنها كحالة حصبة وتبدأ الإجراءات الوقائية. طبعا احنا بنتكلم عن الحصبة نتكلم عن very highly infectious disease، بحيث انه الشخص اللي يكون مخالط، وتعريف المخالط يعني جدا ضاري. المخالط هو أي شخص حتى دخل الغرفة اللي كان فيها شخص مصاب بالحصبة لمدة ساعة بعد ما خرج الشخص المصاب ودخل الثاني الغرفة هو يعتبر مخالط، لأنه airborne، الحصبة تعتبر airborne. لذلك بمجرد اشتباه حالة الحصبة يعزل المريض أو المشتبه بحالته under contact droplet precautions in a negative pressure room يعني airborne. تؤخذ طبعا عينات الدم والثروت سواب من الشخص المشتبه بحالته for confirmatory testing، وإذا كانت positive طبعا يستكمل العزل والعلاج، وإذا كان negative فcase discarded. قبل التأكد أيضا من الحالة وقبل ما تظهر النتيجة المخبرية يبدأ حصر المخالطين للميزلز. جميع المخالطين لابد أنهم يعطوك evidence أنهم هم إما سبق لهم التطعيم عن طريق كروت تطعيم أو دليل مناعة سابقة، عندهم IgG بتحليل سيرولوجي عملوا لي أي سبب من الأسباب قبل كده، وإلا فإن هذا المخالط طبعا باعتبار أنه ما هو سيمتوماتيك، لأنه لو كان سيمتوماتيك وهو حالة مشتبهة هذا المخالط حيكون عنده إجراء وقائي من أصل ثلاثة. إما أنه هذا المخالط يكون خالط الشخص المشتبه حالته خلال ال 72 hours اللي راحت وليس أكثر من ذلك، إذا أنا أقدر أعطيه تطعيم ال MMR، يأخذ ال MMR فاكسين، وكمان تتم مراقبته لمدة 21 يوم يوميا للتأكد من عدم وجود الأعراض، لأنه هو في الأخير الفاكسين ما يعطينا 100% prevention من المرض، فلو ظهرت الأعراض خلال 21 يوم إذا هي حالة مشتبهة. أما إذا كان التواصل أو المخالطة مع الحالة المشتبهة خلال 6 أيام، يعني حصلت قبل 6 أيام أو في ذي الفترة أكثر من 72 hours، أو لو افترضنا إنه ال MMR is contraindicated لهذه الحالة، مثلا تكون pregnant female أو طفل أقل من 6 أشهر، يعني إحنا we can extend it. هو في الحقيقة ال MMR يعطى إلى 12 شهر من 12 شهر، لكن إحنا في حالات الأوت بريك أو الاشتباه بننزلها إلى 6 شهور، ما هي مشكلة. لكن في هذه الحالات اللي بتكون contraindicated فيها يفترض إنه يعطى المريض immunoglobulin IgG أو IM حسب المتوفر IV أو IM، ويعزل كارنتين حجر منزلي لمدة 28 يوم، الفترة أطول الآن، ويتابع يوميا لظهور الأعراض، وبمجرد ظهور الأعراض يعتبر حالة مشتبهة. طيب السيناريو الأخير إنه يكون التواصل مع الحالة المشتبهة في فترة أطول من 6 أيام، عدت أكثر من 6 أيام، أو ما كان متوفر ال IgIM أو ال IgIV، ما أخذ أو ما أعطى لأي سبب من الأسباب، إذا ما يبقى غير إنه هذا الشخص يخضع للحجر كارنتين لمدة 21 يوم، ويتم مراقبته يوميا لحدوث أي أعراض and signs and symptoms. طبعا نتكلم عن الحجر في الميزلز، نحن نتكلم عن population that is very vulnerable في الكوميونتي اللي هم الفيميل pregnant females. زي ما نعرف الميزلز من الأمراض المعدية إذا أصيبت بها المرأة الحامل في بداية الحمل بيكون نسبة التشوهات في الجنين والمشاكل الخلقية عالية جدا، فهذا واحد من الأسباب المهمة، بالإضافة إلى أنه نسبة انتقال العدوى في الناس الغير محصنين تصل إلى أو تزيد عن 90%، لذلك الإجراءات الوقائية بتكون مشددة. طيب ننتقل إلى البوليو أو البوليومايلايتس. الاشتباه دائما في البوليو يبدأ بحالة شلل رخو حاد، خلاص طفل أو adult يصاب ب acute flaccid paralysis، مو شرط يكون بوليو طبعا، احنا نعرف ممكن يكون المننجايتس السيمبلز مننجايتس يظهر على هذا الشكل، ممكن يكون جينيان بار سيندروم، ممكن يكون اسباب كثير نيورولوجيكال نون نيورولوجيكال الى غير يعني خلافه، كثير منها اوتو اميون ديزيزز، لكن السسبشن لازم يكون جدا عالي في البوليو بحيث ان احنا نبلغ عن اي حاله acute flaccid paralysis as بوليو، لانه من الامراض المستهدفه بالاستئصال من المملكه العربيه السعوديه ومن العالم بشكل عام. فالريبورتينج المتكرر للحالات المشتبهة يحقق هذه الغاية. طبعا عند الاشتباه هذا الشخص المشتبه بحالته يعزل، ويعزل تحت الكونتاكت بريكوشنز فقط، وتأخذ منه 2 stool samples separated by 24 to 48 hours، ما تتاخذ في نفس الوقت، وترسل for confirmatory testing لمختبر هيئة الصحة العامة. ويبدأ طبعا التقصي النشط للمخالطين. في البوليو المخالطين للحالة يتم متابعتهم يوميا لمدة 30 يوم لظهور الأعراض والساينز والسيمتومز، وطبعا لو ظهرت عليهم أي أعراض هم كلهم حيكونوا حالة مشتبهة. النقطة المهمة والإجراء الوقائي المهم جدا في حالة اشتباه البوليو بمجرد الاشتباه وبدون حتى التأكيد أن يتم تطعيم جميع الأطفال اللي عمرهم أقل من 5 سنين في النطاق السكني المحيط بالحالة محل اكتشاف الحالة بجرعتين من لقاح الأورال بوليو فاكسين separated by 1 month لجميع قلنا الأطفال اللي عمرهم أقل من 5 سنين. وهذا الكلام طبعا ينطبق أيضا على مو بس الحي السكني، المدارس، الحضانات، المخيمات عند الحجاج. طيب طبعا في حالة كانت تيست بوزيتيف it is polio. إذا كان طبعا إذا هو بوليو ويتم عزل الحالة إلى أن يكون عندنا 2 stool samples تؤخذ 7 days apart وتكون كلها الاثنين نيجاتيف. ديك الساعة ينتهي العزل. وبالنسبة لي نقطة في نهاية عملية التقصي لحالات البوليو، دائما هذه النقطة تنسى. هناك شرط إنه أي حالة اشتباه بوليو ابتداء سواء كان تم تأكيدها أو لم يتم تأكيدها، أي حالة acute flaccid paralysis لابد من مراجعتها clinical review بعد مرور 60 يوم من الحالة وتحديث الحالة هل الويكنس هذا أو الفلاسيد paralysis تم التعافي منه ولا حصل له progression ولا إيش كان بالضبط التشخيص تبعها. طيب ننتقل إلى المننجايتس، وهنا إحنا بنتكلم سبيسيفيكلي عن المننجيكوكال مننجايتس، بكتيريا المننجايتس. طبعا بمجرد اشتباه الحالة نحن نعرف الكلينيكال بيكتشر من وين do you suspect meningitis. في الأخير اللي يهمنا إنه بمجرد اشتباه الحالة تعزل droplet precautions droplet، وتعزل طبعا قد إيش 24 hours after starting antibiotics. بمجرد ما تعدي 24 ساعة من بداية الانتيبيوتكس you can break the isolation ويبدأ الكونتاكت tracing، وحنشوف الكونتاكت symptomatic إذن هما suspected case، وما هم symptomatics حنتكلم الآن عن إجراءاتهم الوقائية. الحالة المشتبهة تأخذ لها عينة confirmatory CSF fluid عن طريق اللمبر puncture قبل بدء المضاد الحيوي، ثم إذا كانت positive إذن هي confirmed case. حتى إذا كانت negative with high clinical suspicion you can continue treatment as meningitis. طبعا confirmed case تستقبل الايزوليشن، وفي نهاية العلاج وقبل خروج المريض لابد أن يأخذ جرعة ريفامبيسين or third generation cephalosporin عشان نعالج الكارير ستيت. الكارير ستيت واحدة من أهم المشاكل اللي عندنا في meningitis، الشخص ما تكون عنده أعراض لكنه يكون معدي للآخرين، فعشان كذا بنهاية العلاج يأخذها. أما بالنسبة للمخالطين فعندنا 3 إجراءات وقائية. أولاً التطعيم. اللقاح أو لقاح المننجيكوكل ما يعتبر الآن إذا تم أخذه بعد المخالطة post exposure prophylaxis، ولكن هو يعطى كopportunistic vaccination. إحنا نستغل الفرصة إذا اكتشفنا إنه هذا المخالط لم يتم تطعيمه قبل كده ونعطيه اللقاح. هذا رقم 1. ثاني نقطة البوست exposure prophylaxis. فعلياً هو عبارة عن antibiotics treatment يعطى، هذا البروتوكول يعطى خلال 24 ساعة من المخالطة للحصول على أفضل نتيجة، ولا يعطى إذا تجاوزت الفترة تبع المخالطة، تجاوزت 2 weeks يعني خلاص عدى already 2 weeks على their last contact. ويستمر متابعة الحالات طبعا لمدة 10 أيام عشان تظهر نشوف إذا ظهرت أي signs and symptoms. إيش هي البوست prophylaxis؟ عندنا الادلتس عندهم 3 خيارات وتكون كلها single dose antibiotic. الchildren لهم specific options ceftriaxone or rifampicin. For pregnant women they only have the option of having ceftriaxone IM single dose 250 milligrams. الكوليرا، طبعا الكوليرا تنتشر بشكل كبير في الحشود. لما يكون في عندنا اماكن زي المخيمات في الحج ممكن الريسك عالي جدا للاصابه بالكوليرا. لما يكون في عندنا shared water sources shared food sources كوليرا ريسك عالي. الاشتباه بيكون بمجرد having watery diarrhea مكتوب هنا suspected case، بالاضافه الى recent travel to from a cholera endemic country. طبعا الكوليرا endemic countries بنتكلم عن الهند، باكستان، بنغلاديش، كذا دول معينه محطوطه في القائمه، بالاضافه الى زي ما قلنا severe vomiting severe dehydration absence of abdominal pain، الكلينيكال بيكتشر اللي كلنا عارفينه. بمجرد الاشتباه ينعمل لهم للحالة المشتبهة الرابيد تيست. الرابيد تيست عبارة عن كت سريعة تظهر نتيجتها في 5 إلى 15 دقيقة، مباشرة نقدر نعرف إذا الحالة نيجاتيف أو بوزيتيف. إذا كانت الحالة بوزيتيف إذا هي confirmed case، هذا الشخص المشتبه بحالته يعزل عن بقية الناس الموجودين معاه في المخيم، ويكون contact precautions. وبالنسبة للمخالطين اللي ما عندهم أعراض نفرقهم عن الحالة المشتبهة، يكونوا في مكان لوحدهم، ويبدأ الريهايدريشن ثيرابي والأنتيبيوتيك ثيرابي. أما الكونتاكتس ما يحتاج نحجرهم ولا نعزلهم، مجرد إنه خلال ال5 الأيام بعد مخالطتهم لهذه الحالة نطلب منهم إنهم avoid drinking من common water sources، يستخدموا their own bottles أو their own water source، و avoid handling or serving food to others، و no quarantine or isolation is required, only follow the hygienic precautions. وخلال هذه ال5 الأيام لو ظهرت الأعراض على أي واحد من المخالطين يصبح suspected case. طيب البوست اكسبوجر بروفيلاكسس في حالات الكوليرا، إذا كان الشخص طبعا asymptomatic يقدر ياخذ البوست اكسبوجر بروفيلاكسس اللي هو oral doxycycline 1 dose 300 ملغ and follow up for 5 days. إذا كانت pregnant female أو كان child أقل من 12 سنة يستعاض عنه بالازيثرومايسين في pregnant females 1000 PO 1000 ملغ PO once، وإذا كان child 20 ملغ من الازيثرومايسين برضو. طيب ننتقل إلى آخر نقطتين، الكوفيد 19 والإنفلونزا. suspected cases طبعا في الكوفيد 19 عارفينها. when do you suspect COVID-19؟ الفكرة هي إن حالة الكوفيد 19 بمجرد اشتباهها الكونفirmation حقها يكون عن طريق الرابيد تيست. once إنه الرابيد تيست يطلع positive إذا هذه confirmed COVID-19 case. المطلوب طبعا إذا كانت stable case خلاص مجرد home isolation أو في مقر السكن لمدة 5 أيام منذ ظهور الأعراض. and case هذه الكيس حتتم يعني مساعدتهم في أداء المناسك بوجود احتياطات وقائية strict precautions عشان الحفاظ على صحة بقية الحجاج. أما إذا كانت الحالة unstable فهي تعزل في منشأة صحية تحت droplet and contact precautions، وممكن تصبح airborne إذا كان في عندنا aerosol generating procedure. الكونتاكتس كلهم باي ديفينيشن حيكونوا هنا الديفينيشن حق الكونتاكتس إذا كانوا symptomatic فهم suspected case، أما إذا ما كانوا symptomatic you will follow them يوميا لمدة 14 days. إذا ظهرت عندهم الأعراض فهم حالة مشتبهة، وإذا لم تظهر فهم سليمين. وأخيرا الإنفلونزا. طبعا حالات الإنفلونزا يهمنا نعرف فيها كذا نقطة. في susceptible categories للسيفير انفلونزا، هذول هم الأهم يعني أن نضعهم في عين الاعتبار عند التقصي. الأطفال أقل من 5 سنين، البريجننت فيميلز، الدري أكثر من 65 سنة، اللي عندهم أمراض مزمنة، واللي بيكونوا عندهم في long term facilities، وكمان اللي عندهم غسيل الكلى. تعريف المخالط الآن بالنسبة لي الاشتباه حق الحالة أي شخص عنده close contact مع حالة مؤكدة من الإنفلونزا وبدأت تظهر عنده influenza like symptoms. الانفلونزا like symptoms هي مكتوبة هنا، درجة حرارة فوق 38 بالإضافة إلى sore throat cough congested nose إلى آخره. هذا الشخص إذا ما كان من ال highly susceptible populations وأموره طيبة، إذا هو you only monitor this person for 5 days كمخالط إذا ظهرت عليه الأعراض ولا لا. أما إذا كان مخالط ما عنده أعراض لكن هو واحد من هذه البوبيليشن عالية السسبتبيليتي والفولنربيليتي، يبدأ يتعاطى حتى هو ما عنده أعراض، ياخذ الأورال أو سنتاميفير اللي هو التاميفلو 75 ملغ once daily for 10 days. خلاص. طيب نقطة أيضا نحطها في بالنا، إذا كان المخالط سيمتوماتيك إذا كان يحتاج التنويم ولا لا. في حال إنه ما يحتاج التنويم بس بينعطي الأورال أو سنتاميفير 75 ملغ twice daily for 5 days. أما إذا كان يحتاج التنويم فبينعطي أورال أوسلتاميفير 75 ملغ twice daily for 5 days، ويمكن زيادة هذه الجرعة بناء على السيفيريتي of respiratory symptoms. وطبعا adjust the dose for patients with renal failure. شكرا لكم، كذا خلصنا المحاضرة أخيرا. إذا عندكم أي سؤال تفضلوا. يعطيكم العافية. تفضلي. لا، اصلا الفاكسين فور ايبولا ما زال نون FDA approved، وما زال اندر ستديز، فما زال لم يتوفر لا في العالم ولا في المملكه العربيه السعوديه، ولكنه اندر ستدي. لكن المونكي بوكس يس موجود ومتوفر وبيعطى. سؤال ثاني؟ متوفر عندنا في الطب الوقائي، وفي ستوكات معينه سيتم توزيعها برضو في المنشآت الصحيه عند الاحتياج، بس هو اهم شيء يهمنا انه هو متوفر في التجمع الصحي لمكه المكرمه في حال الاحتياج. اي سؤال ثاني؟ تفضلي. مرحبا. And directly will deal with the mass Hajj. But I have a question: is that those rapid tests we talked about, is it confirming or diagnostic, or if we suspected any cases, we can transfer them? Then, but what about if we are suspected also we are working with those cases? تمام، يعطيك العافية. بالنسبة للرابid تيست اللي تم ذكرهم في operational protocols، rapid test for cholera, rapid test for COVID-19, they are confirmatory. خلاص. However, samples for cholera are taken to be sent to مختبر هيئة الصحة العامة في الرياض for PCR analysis and isotyping. لكن confirmatory test, it is considered as a confirmatory test في بالنسبة للكوليرا and COVID-19. هذه الكيتس اللي احنا ذكرناها في البروتوكولز. Otherwise other tests احنا كتبناها بالتفصيل. Most of the other tests بتكون blood sample او swabs، هذه بتنعمل لا بتتاخذ و you have to refer it، ما حيكون في in the same location. This case has to be referred to a healthcare facility. I have another question. For us as the volunteers working in Arab. طيب، أول شيء يعطيكم العافية وما نستغني عن جهودكم. أعتقد البست advice إنه to cooperate with health care delivery teams المتواجدين الميدانيين والموجود اللي هم لهم علاقة بمستشفى الحرم ومستشفى الطوارئ، يعني ما يكون العمل فردي. الشيء الثاني، هذه البروتوكولز أتمنى أنها تكون توصلكم، وإنكم تكونوا على اطلاع بالsuspected case definition، وهذا موجود بشكل تفصيلي في الدليل الإجرائي للحج والعمرة. إذا ما كان عندكم ممكن يوفر، ولكن في البروتوكولز مكتوب بشكل مبسط. Thank you. أي سؤال ثاني؟ يس. برضو عندنا في التجمع في الإدارة التنفيذية للطب الوقائي. في النور إيش رأيك دكتور؟ الرابid تيست للكوليرا اللي هو متوفر في مستشفى النور؟ يتم طلبه إذا هم اللي معهم. تمام، يعطيكم العافية. شكرا لك. كيف هذا نشيله؟ لا دقيقة. شكرا لك. شكرا. الله يخليك.
For your informative presentation. We are pleased to welcome Dr. Mohammed Al-Harazi. Dr. Mohammed is a preventive medicine consultant, Executive Director of Preventive Medicine and Prison Health at Makkah Healthcare. He is a head of Preventive Medicine and Public Health Department at Herat General Hospital. Today, he will sharing with us his expert opinion on preventive management of needle stick injuries during Hajj. With that, I ask you to give your full attention to Dr. Al-Harazi and help me in welcoming him to the stage. Dr. Mohammed.
طيب لازم يعطيك العافية. دكتورة، هذا أظن تخليه عندك، تبي تمشيه لو واحد عنده سؤال، بس أظن قفل. طيب طيب بسم الله، الحمد لله والصلاة والسلام على رسول الله. أنا أخوكم محمد الحرازي. إن شاء الله يكون موسم حج ناجح ومذهل، وأمر الله يكون خالي من الأوبئة والأثر ذا على الصحة العامة. حناخد فكرة بسيطة عن موضوع النيدل ستيك. الصوت ما كان واضح. اوكي ما شاء الله. الشماغ صعب. هلا، ان شاء الله يكون تمام. كيف الصوت؟ احسن؟ طيب. بس اللي قلته قبل شويه انسمع؟ طيب كويس. طيب هتكلم معاكم اليوم على النيدل ستيك. قديش how do you think it's common? It's common? Okay. أي منشأة مثلا، ترى من أي منشأة؟ How common needle stick in daily, weekly? Yeah. Okay. Actually, it depends according to the department you are in. If you want to notice how frequent is the needle stick. Unfortunately, last Hajj, one of the consultant from surgical department, he came to me after 5 to 6 days after sticked. Okay. Maybe you cannot believe it that consultant, he knew already that patient was known case of Hep B. But unfortunately, he doesn't know what should I do. Just by chance, after 5 days came, I was on call, I'm tired. I forgot to ask the public health department that I got sticked in OR. Anyhow, I'm just want to tell you that don't think that everybody knows what should you do when you exposed to sticked. The other thing I want to tell you is I hope it's same protocol for everyone. حختار مثلا دكتور من أي منشأ؟ KMC. إيش البروتوكول once أي أحد تعرض من الستيك؟ report and then okay. Okay. مكافحة العدوى available 24 hour. طيب. أحد معانا حيكون مرابط في المشاعر هنا؟ مشاعر؟ أوكي. حرام. مشاعر؟ لا كلكم ما شاء الله. طيب. الفكرة this year إن شاء الله we have like make distribution for the post exposure prophylaxis للنيدل ستيك. حيكون ان شاء الله السنه هذه. العام كان متوفر فقط في المستشفيات. السنه في ان شاء الله تعتبر كل المراكز الصحيه. لكن هي actually by number 25 primary health care في منشآت منى وعرفه ومزدلفه. فاللي حاب اقوله انه ان شاء الله السنه هذه نبغى الكل يكون عارف ايش الاجراءات اللي انت المفروض تسويها وانس لا قدر الله تعرضت للنيدل ستيك. ان كنت في المشاعر كل مركز صحي، المعلومه مهم انها تكون عندكم كلكم. كل مركز صحي اقرب مركز يكون متوفر فيه البوست اكسبوجر بروفيلاكسس بالكثير 2 3 minutes walking. لكن بالنسبه للمستشفيات ان شاء الله الكل جميع المستشفيات في المشاعر متوفر فيها الاجراء اللازم. طيب للتذكير once لا قدر الله صار النيدل ستيك sometimes ترى ما هو related فقط للخبرة. no, sometimes maybe your colleague, your friend, the nurse, the doctor can sick you and maybe someone is not around you who just left the needle open without recapping. We're always saying like don't recap. Sometimes you need, but if you need it just use the one hand technique. طيب first of all you will remove the gloves. Sorry. Yes, don't squeeze. Okay, don't squeeze. Do not scrub. مجرد washing. Soap not available. نستخدم الكحول. طبعا قبل حنكون شايلين gloves. ما سمعت. ممتاز. Okay. الشارب كونتينر. الموست كومن كوز النيدل ستيك غالبا ايش؟ الاو ار ولا نيدل ليفت without recapping؟ يعني انا ما اتكلم ايش الصح، اتكلم من خبراتكم انتم ايش شايفين؟ من سامع؟ اوكي. And many cases like in my hospital a needle sometimes when it's thrown in the normal container, when the like any cleaner will take it, it will be sticked. طيب. بالنسبة لمستشفيات المشاعر الإبلاغ لقسم مكافحة العدوى. أما بالنسبة للمراكز الصحية الإبلاغ لمدير المركز. بالنسبة لكل مستشفيات مكة الباقية أجياد، الحرم، حراء، النور، KMC، الزاهر، الجميع أقسام الصحة العامة يبلغوا بها. مجرد للتذكير ترانسميشن. نسبة الترانسميشن نحن نخاف من ايش في النيدل ستيك؟ ايش؟ هيباتيتس بي وايش؟ اوكي. طيب ايش نقدر نعمل regarding الهيباتيتس سي؟ فولو اب. السي فولو اب. طيب البي ممتاز. الاتش اي في النسبة قلنا في حالة الهيباتيتس بي 30%. 30% قديش ممكن تخف تنزل قديش في حالة استخدمنا البوست اكسبوجر؟ It will be down to less than 5%. أما بالنسبة ل HIV you can decrease the percent of getting the risk of HIV infection with 66%. لذلك مهم جدا التدخل. الناس دائما تقول متى. Sometimes الناس اللي interested في policy whatever الاقيه كاتب 48 hours. اوكي بس انه المفروض نكتب as soon as possible. Once your investigation is ready you can start your management. الحج وقت الحج له وضع خاص. ما احنا ما لسه المختبر اللي خاص اللي يقدر يطلع الهيباتيتس بي انتيجين او الهيباتيتس سي انتي بودي اتش اي في انتي بودي. serology and western blot will not be ready within an hour, maybe within 1 or 2 days. So in الحج you will start your management immediately. ان شاء الله حتلاقوا كل الادويه جاهزه في اماكنكم. whatever وان شاء الله ما تصير لا قدر الله صار. ارقام الصحه العامه في جداول موجوده في كل منشاه. اتصلوا على الصحه المهنيه، اداره الصحه المهنيه حيوجهوكم باجراء الصحيح، وان شاء الله حيتعاملوا معاكم ومع الفيكتيم او مع الحاج ياخذوا منه العينه عشان ان شاء الله وانس انك تكمل العلاج لا قدر الله مثلا اتش اي في حتكمل 2 3 رابع يوم تطلع النتيجه ان شاء الله. ان كان بوزيتيف لا قدر الله حتكمل الشهر، نيجاتيف خلاص you can stop the medication. الهيباتيتس بي ان شاء الله ان صار لا قدر الله برضه حتاخده قبل ما يبدا الحج بليز. نبي نشيك متى، خلي الاجابات دي جاهزه. اكيد حيقول لك متى اخر مره طعمت، حتعطي رقم. حيقول لك كهيلث كير وركر مثلا نختار انفكشوس ديزيز ما نستطيع. طيب متى اخر مره طعمت هيباتيتس بي؟ اخر واحده يس ما طعمت. خليت من انت ها في النور. طيب هو as we know hepatitis B 3 doses you have to keep your titer above 10. بس هو غالبا لو طعمت الثلاثه ما حتلاقيه above 10، حتلاقيه 100 1000. so نبغى نطمن عليكم الهيباتيتس B is not curable so go and get vaccinated. طيب طيب يعني الاتش اي في بروفيلاكسس عباره عن 3 tablets a day، واحده كل 12 ساعه وواحده كل 24. ان شاء الله بامر الله ولا واحد فيكم يكملها تطلع النتيجه نيجاتيف للسورس للحاج. بس لازم تطمن، لازم نحن ما قدرنا نوصل ان احنا نهتم بالهيلث كير وركر في اعلى الدرجات ترى ما حنقدر نهتم بالمرضى والحجيج. احد عنده استفسار؟ يعطيكم العافيه وشكرا جزيلا. لا ايوه تعال تعال صح هو الحضور بعض الأحيان ان شاء الله في اليوتيوب كمان، وبرضه منقوله على الزوم اليوم الاول في رابط للزوم وفي رابط اليوتيوب، يعني برضه في اخوان بيتابعونا على اليوتيوب وعلى الزوم كمان. تمام، فيمكن كده الواحد يعني الحضور لو تبغوا حابين كده بس الواحد يعني يحس انه في حضور كده مشكرين، يعني ما شاء الله عليكم. تمام، فجزاكم الله خير، بس حبيت اعطيكم خبر. اوكي. طيب طيب الآن المحاضرة بعنوان Community Acquired Pneumonia Management Food Poisoning Meningitis مع الدكتورة ريم أحمد المالكي Internal Medicine and Infectious Disease Consultant, Chairman of Antibiotic and Septicemia Committee, Head of the Antimicrobial Stewardship Program, Head of the Internal Medicine Department at حراء General Hospital. حياك الله دكتورة.
طيب السلام عليكم. Welcome everyone. I'm so glad that you could join us today in this symposium. I'm Dr. Reem Al-Maliki. I will talk briefly about community-acquired pneumonia. We know that in a crowded area like in Hajj season, we may have increasing rate of community-acquired pneumonia. Pneumonia per se is a respiratory infection or inflammation in lung parenchyma. And pneumonia is commonly transmitted through aspiration or droplets or airborne pathogen. Community-acquired pneumonia is a pneumonia acquired outside the healthcare facility. Most likely causal pathogen can be narrowed to based on patient age and patient immune status. Pneumonia is classified based on clinical features as either can be typical or atypical. Each type has its own spectrum of commonly associated pathogens. We'll start with the first class, which is typical pneumonia. With Streptococcus pneumonia is considered the most common organism causing community-acquired pneumonia typical presentation. It's a gram-positive diplococci. The rate is increased within time from 65% to less than 12%. The virulence factor for Streptococcus pneumonia is the capsule to invade the immunity and causing pneumonia. Second, the type of pathogen is Haemophilus influenza, also using the capsula to invade the body and as a shield or a fight for this bacteria to fight our body. Third is Moraxella catarrhalis, Klebsiella pneumonia, Staphylococcus aureus, gram-positive cocci in cluster. We should consider it if patient present with complicated pneumonia with pleural empyema, or if there is cavitary lung lesion or necrotizing pneumonia. Second is the atypical pneumonia. Second classification is the atypical pneumonia. They classified on bacterial and viruses. For bacterial, Mycoplasma pneumonia, gram-negative, also gram-negative bacilli can cause interstitial infiltration. It's usually very dry cough presentation with extrapulmonary manifestation, either CNS, patient can present with meningoencephalitis or GBS. There is also other skin manifestation with Mycoplasma pneumonia, is erythema nodosum, or patient can present with Stevens-Johnson syndrome along with the pneumonia symptoms. We have also chlamydophilia pneumonia, chlamydophilia pesticide. Legionella is common if the patient has travel history or contact with contaminated water. Coxella burnetii, very rare, usually with farmer patients. Francisella tularensis, also very rare with hunter or farmer. The viruses, RSV, most commonly with children or infants. Influenza, parainfluenza. CMV, very rare, unless your patient is immune compromised. Adenovirus, coronavirus. The other classification based on the location, patient can present with local pneumonia. They classify this most commonly with Streptococcus pneumonia, less commonly with other organisms like Legionella, Klebsiella, Haemophilus influenza. For bronchopneumonia, most commonly with Streptococcus pneumonia and Staph aureus and Haemophilus influenza. Interstitial pneumonia was mainly going with atypical infection or viral infection. Who's at risk factor to get community-acquired pneumonia? Old age patients or patients with chronic diseases, CKD, CLD, patients with cardiac diseases, patients on immune suppression, or impaired airway protection. What's the clinical feature? I'm sure everyone knows it. The clinical typical presentation with productive cough, fever, chills, severe malaise, or by the examination, your patient is tachypneic, tachycardic, pleuritic chest pain. By the auscultation, you will find bronchial air breathe or crackles. Atypical pneumonia typically has indolent course. It's slowly progressing. Patient will present with non-productive dry cough, dyspnea. Auscultation can be unremarkable. Common extrapulmonary feature including fatigue, headache, sore throat, myalgia, and malaise. Diagnostic investigation, the basic lab investigation you are doing, like CBC, inflammatory marker, CRP, procalcitonin, ABG. We don't rely on laboratory markers like CRP or procalcitonin to decide if this patient needs antibiotic or not. Other microbiological studies you can do for your patient, if patient came from other facility or you think this patient can be colonizer for MRSA, we can do MRSA nasal swab because it can subsequent to MRSA pneumonia. For the latest guideline, they recommend the patient present with severe cough. This is indication to send for sputum culture, blood culture. If patient require ICU, we can send for pneumococcal urinary antigen Legionella, pneumophilia urinary antigen. This is in the guideline, but in the real life, mostly it's not available. Influenza season, only if it's circulating in the community, we can send for influenza. In pandemic or epidemic setting, rule out the prevalent respiratory pathogens. Like before, we were sending COVID test for each patient because it was circulating. Avoid routine blood culture and sputum gram stain in patients with community-acquired pneumonia, except if severe or there is concern for MRSA or Pseudomonas infection. As we said, by the imaging, you will either find with typical pneumonia, lobar pneumonia. As you can see, it affected the whole loop with air bronchogram. Or you will find bronchopneumonia defined as patchy infiltration with air bronchogram, which commonly with Streptococcus or Staph aureus. Or you will find interstitial pneumonia, reticular infiltration, mainly with viral or atypical organism like Mycoplasma, Legionella. Typical pneumonia usually appear as local pneumonia on chest X-ray. Consider chest CT or empiric treatment if clinical suspicion for community-acquired still high, but the X-ray is normal. Other diagnostic investigation you may do if patient presented with complicated pneumonia. With empyema, you can do diagnostic thoracocentesis or therapeutic thoracocentesis or tube thoracostomy if pleural empyema is considered or complicated effusion is suspected. For the management, even with modern molecular methods, most of the sputum culture is negative, up to 70%. Antibiotic therapy standard before is to start antibiotic within 4 hours. Now they recommend to start as soon as possible. And if your patient presented with septic shock, they prefer to start in 1 hour. After you start the treatment, you will follow your patient in 24, 48 hours and evaluate if there is any response to the antibiotic or not. The duration of therapy, the recommended duration is 5 to 7 days alone. Could be sufficient if your patient is febrile with no supplemental oxygen use. What about adjunctive therapy like corticosteroid? Is it recommended? Data is very limited to use corticosteroid for community-acquired pneumonia or viral pneumonia. It's still controversial. Most of the guidelines don't recommend using unless your patient has a refractory shock. The major criteria for ICU admission, I'm sure everyone knows it, is to admit the patient. The major criteria, if patient septic shock, need vasopressor, or your patient in mechanical ventilator. Other minor criteria, you may consider admit your patient to ICU if your patient had confusion, hypothermia, tachycardic, tachypneic, or by lab, if you saw that your patient is going like to sepsis, there is leukopenia, thrombocytopenia, or high urea level. The duration of therapy, as we mentioned, all the current guidelines recommend short duration, 5 to 7 days alone. You may consider extend the course in specific situation if your patient have suspect or concern for MRSA or Pseudomonas aeruginosa. If your patient has not responding to treatment or there is susceptibility of unusual pathogen. These are the guidelines of 2019 latest guideline for community-acquired pneumonia. They answered around 16 questions for the most common questions. We were their first question was, should gram stain and culture of lower respiratory secretions be obtained at the time of diagnosis? They recommended not to outpatient setting, only in inpatient setting if your patient has severe community-acquired pneumonia or patient being treated empirically for MRSA or Pseudomonas or previously infected with MRSA and Pseudomonas. Same as for blood culture, it's not routinely recommended to be done for each patient unless your patient has severe community-acquired pneumonia or you treated your patient empirically with MRSA or Pseudomonas. Should Legionella pneumococcal urinary antigen testing be performed at the time of diagnosis? Not for all patients. They only recommend it in the guideline for severe community-acquired pneumonia or if there is suspicion for Legionella outbreak. Should respiratory sample be tested for influenza virus for each patient at time of diagnosis? Again, it's not recommended. Only if the influenza virus is circulating in the community, then you have to do it. Should we rely on procalcitonin plus clinical judgment or using only clinical judgment to withhold initiation of antibiotic? They recommend that empirical antibiotic therapy should be initiated in adults with clinically suspected radiological confirmed community-acquired pneumonia, regardless the initial procalcitonin. Should clinical prediction rule plus clinical judgment or clinical judgment alone be used to determine if I will admit this patient as inpatient or outpatient? In addition to clinical judgment, they recommend clinician use to validate the clinical prediction rule for prognosis. They prefer pneumonia severity index over the Kirby score to determine the need for hospitalization in adults diagnosed with community-acquired pneumonia. Should clinical prediction rule with clinical judgment or clinical judgment alone be used to determine inpatient ward or ICU? They mentioned before the criteria for admission the patient to ICU, as we mentioned before, the major and the minor criteria. In the outpatient setting, which antibiotics are recommended for empirical treatment for community-acquired pneumonia? They classified either patient has comorbidity or no comorbidity. They define the comorbidity if the patient has cardiac disease, liver disease, CKD patients, or has malignancy. If patient has none of these, we can discharge the patient as outpatient on monotherapy of beta-lactam, most commonly use amoxicillin, or macrolides as monotherapy. If your patient has comorbidities, we can use combination therapy, beta-lactam with macrolide or fluoroquinolone as monotherapy. In the inpatient setting, which antibiotic regimen are recommended for empirical treatment of community-acquired pneumonia in adults without risk for MRSA and Pseudomonas aeruginosa? They divided if your patient has severe inpatient pneumonia or non-severe inpatient pneumonia. If your patient is non-severe and you admit this patient to the ward, to the floor, you can start your patient on beta-lactam plus macrolide or fluoroquinolone as monotherapy. You can cover in both cases if you suspect this patient has MRSA or Pseudomonas, your patient has nasal swabbing positive for MRSA and you think MRSA, or this patient recently discharged from your facility and you think of Pseudomonas, then you have to cover also for Pseudomonas. For severe inpatient pneumonia, they put beta-lactam macrolide, same with non-severe. The other regimen is beta-lactam with fluoroquinolone, not like in severe, non-severe inpatient. Fluoroquinolone can be as monotherapy alone, but in severe cases, it was combination, both beta-lactam macrolide or beta-lactam fluoroquinolone. In the inpatient setting, should patients with suspect aspiration pneumonia receive additional anaerobic coverage beyond standard empirical treatment for community-acquired pneumonia? I think we see this a lot. Actually, the guideline, they don't suggest to start anaerobic because it's mostly gastric content causing pneumonitis, unless your patient gets complicated with lung abscess or empyema. In the inpatient setting, should adults with CAP and risk factor for MRSA Pseudomonas be treated with extended spectrum antibiotic? They removed this definition from the latest guideline because they saw many patients started empirically on anti-pseudomonal with no need. So they recommend that clinicians only cover empirical if locally validated and risk factor for either pathogens like patient with chronic lung disease. In the inpatient setting, should adults with community-acquired pneumonia be treated with corticosteroid? We mentioned they don't recommend it to use it even for severe community-acquired pneumonia or for influenza. In adults with community-acquired pneumonia who test positive for influenza, should the treatment regimen include antiviral therapy? we should include it as long patient admitted with community-acquired pneumonia with positive influenza, regardless the duration and when the patient duration of illness before the diagnosis. In adults with community-acquired pneumonia who test positive for influenza, should the treatment regimen include antibacterial therapy? Like in COVID, it was viral, but all patients was admitted with antibacterial. The guidelines suggest only if it's radiological, clinically confirmed this patient have super-added infection, super-added bacterial infection. In outpatient and inpatient adults with community-acquired pneumonia who are improving, what's the appropriate duration of antibiotic? We mentioned that all the guidelines recommend and they did many RCPs for it. They recommend short duration, not minimum than 5 days, the duration 5 to 7 days. In adults with CAP who are improving, should follow-up chest imaging be obtained? No need, unless your patient is not improving or not responding on the antibiotic you are giving. What's the complication of pneumonia? Parapneumonic pleural effusion, pleural emphysema, lung abscess, ARDS, respiratory failure, and sepsis. The prognosis, mortality increase with age. The mortality increased with increasing the curve score. It can be up to 40%. The prevention, as Dr. Ala said, it's by vaccines, pneumococcal vaccine or influenza vaccines, or smoking cessation, because some smokers colonized with streptococcus and Haemophilus influenza. For follow-up, if your patient is improving and fit the criteria for switching from IV to oral therapy, you can switch based on the antibiotic. If the pathogen was identified, you can target this pathogen and discharge your patient on antibiotic to complete his course. If no pathogen is known, use oral therapy similar to the IV agents you are giving during admission. Routine chest X-ray follow-up is not needed if clinically resolved. Consider it if your patient is heavily smoker, more than 50, after 12 weeks to rule out lung cancer. Non-responder to initial therapy defined as 48 to 72 hours. The main culprit is that patients either have things other than pneumonia, either malignancy, emphysema, blood fever, bronchiolitis obliterans, organizing pneumonia, or other non-infectious pneumonic problem. Consider consulting pulmonology or infectious disease for unresponding patients. Macrolide fluoroquinolone can cause prolonged QT interval, especially in severely ill patients. At risk, doxycycline may be suitable for atypical pathogen coverage. Thank you. Anyone have any questions?
In this one only, that was what I يصير عندنا كرايسس، يصير عندنا مستشفيات تكون كرايسس او الناس اللي عايشين سواء اي مستشفى، سواء كانت مستشفى داخل المنطقه او كانت مشاعر. المشاعر اقول لك انا في يوم 15 مثلا يوم 20 المستشفيات الموجوده واقف المستشفيات يسوي خلال المستشفيات كل المستشفيات في عندنا حالات موجوده مثلا موجود يكون موجود في حالات نمونيا موجوده جزاك الله خير قال short courses فكان يعني الحمد لله كان نتكلم عن الموضوع والله حسن بدا والله اوكي خرج الحدث يومين 3 ايام ما ايام 7 ايام ماشي بس انت في وضع تحتاج فيه punishment للكراسي اللي احنا موجودين تمام فلا تستخدم تلاقي بعض الاحيان بعض الرجال ممكن ياخذ يعني اي في يعني we should have our own in such a crisis.
Yes, yes, it will be helpful for it.
Now we'll be back again.
We start with the technology consultant, head of technology unit at General Hospital. She will present to us the most common respiratory disease.
يعطيك العافية كريم. بسم الله. طيب respiratory emergencies that we are going to discuss today will be mainly two topics: asthma and COPD, as they are the most common encountered usually in the whole year, especially in Hajj duration. طيب first part will be about asthma. So we'll concentrate only about the exacerbation mainly. So we'll start with the definition. Usually, actually, the GINA guidelines, the most common guidelines or authority regarding asthma, usually they are updating their definition every couple of years due to the extensive research about the asthma and COPD. So the asthma, actually, it's a heterogeneous disease now. Because why we are telling it's a heterogeneous disease, not like before, it's all the same asthma or all the patients are the same. Now we have multiple subtypes, multiple phenotypes of asthma. We have we are studying the molecular level of asthma, why every patient is different from the other. They are not all the same. We have allergic asthma, eosinophilic asthma, allergic eosinophilic, non-allergic, non-eosinophilic asthma, neutrophilic asthma. So there is so many types, and there is some slight different in the management usually, especially when the case gets severe. So that's why it's a heterogeneous disease. Actually, it's not a one disease. So usually characterized by the chronic airway inflammation and defined by respiratory symptoms, the cardinal symptoms of asthma that we will talk about, the common symptoms, of course. And one of the most common defining asthma character is the symptom will be variable on time, and the patient will have good days and bad days. He will not have constant pathway or journey during his disease. And also one of the characteristics is the variable expiratory airflow limitation, which will be defined by usually the pulmonary function test, the pre and post reactivity, and pre and post bronchodilator. It will be positive usually during the PFT. So this is the cardinal symptoms of asthma. Usually it's shortness of breath, chest tightness, cough, and wheeze. This is mainly the symptoms. So actually the asthma is very, very prevalent over the world. This study is in 2015, actually, almost a decade ago. It's 242 million. I believe this number maybe doubled nowadays. So it's a huge burden. So the diagnosis, usually you should have your typical symptoms of asthma. Then you take a detailed history and examination for your patient to make sure the patient has an asthma, not something else. So you have to explore the differential diagnosis and roll them out by your history and examination. Then you confirm your diagnosis by doing the spirometry that we talked about. The point of doing spirometry or pulmonary function test to confirm the variable expiratory airflow limitation. We are doing that by doing pre and post bronchodilator spirometry, looking for positive reactivity tests. So usually the assessment of asthma, there is many scores and let's say measures to define your asthma is controlled or not. This is one of them used by GINA guidelines. There is 4 common questions: the day, time symptoms, night symptoms, and SABA use, and limitation of daily activities. If your patient is having doesn't have anything of these, he's well controlled. If he's having 1 or 2 out of these 4, he's partially controlled. More than that, he's poorly controlled. So asthma exacerbation. So this is the coming 2 slides. They are the main let's say the main bulk of the presentation, and they are they are gathering the whole information of how to deal with your patient when he has exacerbation. Actually, this these diagrams from Saudi Thoracic Society. So it's Saudi guidelines dealing with exacerbation. Actually, we have GINA guidelines of also, but I prefer to bring the Saudi guidelines, Saudi Thoracic Society guidelines. Usually it's 2 slides or two parts. You assess your patient's exacerbation, then you manage your patient. So assessment, you have usually the assessment will contain, to make it easier, some elements from history, some elements from examination, and oxygen saturation and peak expiratory flow rate. This is a piece, test can be done in the ER. So upon these categories, you can you decide your patient is moderate exacerbation or in severe exacerbation or life-threatening. You can always keep it in your mobile just to for easy access. So once you have decide which part, which category your patient in, then you will start your management. So usually in moderate asthma exacerbation, and this is mainly the case for most of the mass or the most likely case you will encounter during Al-Hajj. The last percentage of the most percentage of patients will be in moderate exacerbation. So your aim is just to keep saturation of the patient is like 92 or more. Then you have to give them bronchodilators. This is the details of that. And systemic steroid usually oral steroid is fine. Unless your patient is not tolerating orally, then we'll give him IV steroid. But usually oxygen support, bronchodilators, and prednisolone, systemic corticosteroid. In severe exacerbation, then you can add also the magnesium sulfate to the management, and also usually we can sometimes ask for more investigations like ABG or chest X-ray. This is the recommendation of Saudi Thoracic Society. And the same for life-threatening. Usually, the key point usually in the life-threatening or in defining life-threatening from the other exacerbation, usually the PCO2 level. When you have a normal PCO2 level or high PCO2 level, meaning your patient is fatigued. So he started to use accessory muscles. CO2 level is normal or high. Then most likely he's in life-threatening asthma, and you have to be careful. So again, we're gonna give arrange for his saturation to make sure it's more than 92. Also, the bronchodilators, maybe the dose will be more continuous, and also the systemic steroid, and also the magnesium sulfate again. And they recommend to order for ABG, chest X-ray, and lab work also. So it's a little bit similar. It's better to keep it in your mobile just for easy access. So the next step, you reassess your patient, make sure that your management is doing its job. Once the parameters is here, your patient is improved, you can discharge him. Otherwise, you can repeat your management. You can give him more bronchodilators, what we call back-to-back. The easiest thing or the most common we are using, the nebulization method by SABA and SAMA, here Ventolin and Atrovent. You can repeat if your patient is partially improved. You can repeat the back-to-back nebulization again and reassess him again. Usually the recommendation, this is for normal days of the year. It's 4 hours for you either to discharge the patient or admit the patient. But in Hajj time, usually maybe we have to decide in a shorter matter of time. So either discharge the patient immediately if he's in moderate exacerbation. Otherwise, he's severe or life-threatening. You admit him immediately for management in the ward to save time and to see more patient in the ER. Okay. So this is the message for most patients we are encountering, let's say in the ER. So you have to make sure once you diagnose your patient or he came with asthma exacerbation, you have to send him home on systemic steroid. This is the most important single point. You should not send him after asthma exacerbation without this short course of corticosteroid, because it has many benefits and it will prevent future exacerbation, will prevent more severe exacerbation, will reduce ICU admission, will improve your patient's symptoms, lung function, and especially in Hajj, inshallah, he will not come back to the ER. But if you send him only with bronchodilators and you did not give him this short course, only 5 days, up to 7 days, maybe he will come back to the ER the next day. So the next thing you should give your patient before he goes home or to continue his Hajj, you should prescribe for him ICS LABA inhaler. This is the second most important thing. Whatever the inhaler available in your center or in your primary healthcare facility or whatever. So we have a lot of examples. Whatever you have Seretide, you give Seretide. You have Symbicort, you have Relvar, Flutiform, like Foster. There is maybe 10 different inhalers with the combination of ICS, inhaled corticosteroid, and LABA, long-acting beta agonist. So you have to give the patient combination of these drugs. Just confirm with your pharmacy what do you have, and it's available in your pharmacy that you are working in, and give your patient the inhaler. Third thing, you should advise them to avoid the triggers, because you should explain to them whatever medication you are taking, if it's correct medication, correct technique, good compliance, and he still continue to encounter the triggers, the benefit of the treatment will be lost. Okay, so it's very important. So now we're gonna go to the second part of the lecture, the COPD exacerbation. So usually, again, for COPD, usually the GOLD guidelines, they are the leaders in COPD. So they are almost yearly, they are publishing new guidelines for the COPD. And usually also the definition will be updated almost every year. So the latest definition, usually also again, the COPD, it's a heterogeneous disease again, because now we are exploring that, we have known that the COPD usually is a neutrophilic disease, but now we are finding more subtypes that it can be a mix of eosinophilic and neutrophilic, not only neutrophilic disease. So it's characterized by chronic respiratory symptoms, again, the dyspnea, cough, but here the sputum production, maybe it's more obvious than asthma. And also in the definition, they included the main subtypes of or phenotypes of COPD, which are the chronic bronchitis. The abnormality will be in the airway, or if the abnormality in the alveoli, we have destruction of alveoli, so we have emphysema. So which can cause persistent and progressive airflow obstruction. So it's different from asthma. Asthma, it's variable, but now in the COPD, it's persistent and progressive. So when you do your pulmonary function test, you do pre and post bronchodilator, it will be the same. There will be negative reactivity test. So the risk factor, before we were considering only smoking the risk factor, but actually it's not. It's a lot more than smoking. Smoking is the most common, but we have a lot. Biomass exposure, when we are cooking with the gas, occupational exposure, patient working in the factories, in the coal mining. So all of these can be or can lead to COPD, actually, not only smoking. Any in the previous year, they have updated the definition. They have added, previously it was only smoking. In the definition of COPD, the patient will be a smoker. Now, any exposure to noxious material. So whether it's in the coal mining, in the factories, or smoking. Air pollution also, it can be one of the things that can cause COPD. And genetics, mainly the alpha-1 antitrypsin. It's genetic causes. The patient can develop emphysema and COPD. So this is the main phenotypes known until now. The chronic bronchitis, usually your patient will have the definition of it. He will have chronic productive cough for 3 months, for 2 consecutive years. So you can then diagnose your patient, or his phenotype will be chronic bronchitis. Emphysema, usually it's a pathological diagnosis, which means you have to have an evidence, whether by doing imaging like CT chest, you find emphysema, visible emphysema, or otherwise by biopsy, which is like less common, you find emphysema in your slides, microbiological or histological slide. So this is the main difference between them. So assessment, again, there is multiple scores for assessing COPD, like CAT score and modified MRC score. It's easy to apply. It's biologic. Yani zero, your patient will just only have shortness of breath with severe exercise. Then grade 1, like can you see he will have, and he will be out of breath when he's doing like moderate exercise and so on. Like grade 4, he's even breathless to do his dressing, undressing, so which is like almost with rest. So GOLD guidelines, again, the famous guidelines, COPD guidelines, they have updated their like famous schedule. All of you remember the ABCD. Now it's no more like that, ABCD. Now it's ABE. They found that exacerbation is like the most important element, defining the pathway or the prognosis of your COPD patient. Is he exacerbator or he is not? If he's an exacerbator, so he's an advanced case of COPD. So, for your first step to confirm your diagnosis, as we have mentioned, by doing spirometry, you do your pre and post, it will be the same. So as we said, it's persistent obstruction. You will do, and you will give your patient during spirometry bronchodilators, Ventolin, but still he will have obstruction. In asthma, he will not. He will have positive reactivity, and you give him bronchodilators, his airway will be reopened, and that's what we call positive reactivity test. Otherwise, in COPD, it will be fixed obstruction. This is what we mean by, and in the definition, it's a progressive obstruction. Fine. So assessment of airway obstruction, just or the grading. This is the simplest way to grade the COPD. Once he have lower FEV1, means he's like having more symptoms, worse prognosis. This is like the updated part of the guidelines. They removed the C. So A, your patient is having A and B, they have no serious exacerbation, only one exacerbation not leading to hospitalization, which means he went to the OPD, he went to the primary healthcare, he received bronchodilators, and he has improved. He did not require admission. So he will be A or B. A, less symptoms. As we mentioned, modified MRC, 0 or 1, like he's doing, he can do more exercise without getting shortness of breath. But MRC more than 2, which means he has shortness of breath with mild exercise, or he's unfit to dress himself or undress himself. And he got shortness of breath at rest even. So it will be in category B. Once your patients develop exacerbation leading to hospitalization, or more than 2 exacerbation in a single year, even without admission, so he's an exacerbator. We call him exacerbator, COPD exacerbator. So he's in category E. The benefit of this categorization, just to give you an idea, your patient will have worse scores than the non-exacerbator patient. He will have more exacerbation. He will have lower function test values. He will have low quality of life. He will have more symptoms, and as we mentioned, bad quality of life. So it's really important in the prognosis. So COPD exacerbation. How are we going to manage this patient? Usually in the GOLD guidelines, again, they are advising for bronchodilators. Bronchodilators in form of SABA and SAMA, Ventolin, SABA, like Ventolin, the most common, and SAMA, the Atrovent, ipratropium, bromide, and SABA is the salbutamol. So the second part of the management, usually, and again, we are giving we are giving the bronchodilators in back-to-back matter, like like asthma. Systemic steroid here, usually it's only for 5 days. Before, we used to give COPD patients steroid like 2 weeks. They compared the group of the patient who received only 5 days and the group who received 2 weeks. They found the same benefit. The patient got the benefit in only 5 days, but with less complication of steroid. So 5 days in COPD is enough. Only 5 days. Antibiotics, usually it's used in the management because a lot of patients, they got their exacerbation because of infective or bacterial pathogen. But once you can, let's say, find a solid evidence that your patient has a bacterial infection, you give him antibiotics. Otherwise, if you are in doubt, you can also, like in Hajj, you can give him antibiotics. But otherwise, if you are sure that he's exacerbating because of viral illness, everything is leading to viral, no need to give antibiotics. But especially in Hajj, sometimes you didn't have like time or you didn't have facility, so antibiotics can be used. This is very important point in the managing of COPD patient. You have to make sure your patient, is he a CO2 retainer or not? Because this will decide your oxygen management for this patient. If he's non-CO2 retainer, means his CO2 is normal or low, like asthma patient, you can give him oxygen freely, it's fine. You can keep it even 94% or more. But if he's the CO2 retainer, this is very, very important, because if you give him more oxygen than this, he will start to retain more CO2 and you are worsening his case, not helping him. So especially in the ER for Hajj, we have to make sure, because if you give your patient, COPD patient, more oxygen, he will deteriorate and you will admit him. So this is very important. Just doing a quick VBG or ABG. ABG is difficult, just do VBG, check the CO2. If it's high, make sure to instruct clear in your orders. Do not give more oxygen more than your target saturation should be 88 to 92. If your patient doesn't need oxygen, his saturation is like 90 or 88 without oxygen, you don't have to give him oxygen. It's not mandatory to give oxygen to CO2 retainer. This is also a most important point. Once your patient is started to develop respiratory failure or worsening of symptoms, we will discuss the rationale behind using the BiBAB or the indication of using BiBAB in the coming slides. But BiBAB is the first choice always in COPD patients with respiratory failure, the BiBAB. So this is the indications of BiBAB. Usually if you have, the indication for using NIV or BiBAB. So the acidosis is the most common indication when you have pH less than 7.35. If your patient is really symptomatic, he has severe or increased work of breathing, he's tachypnic, he's using accessory muscles, even without acidosis, we can give him BiBAB to relieve that work of breath. Also, if your patient is having persistent hypoxemia, means that you are giving him supplemental oxygen by nasal cannula or by face mask, but you cannot reach your target 88 to 92, or if your target is like 94 or more, you cannot reach it by conventional oxygen, you go to the BiBAB. So it's very, very crucial to have BiBAB when you are dealing with COPD patient. Otherwise, you're gonna intubate your patient, and we would like to avoid intubation unless it's indicated. So these are the indication of intubation. Once your patient is not tolerating BiBAB, your patient is having contraindication to BiBAB, like these mentions here. Your patient is in cardiac arrest, he's not conscious, he's having severe facial trauma, he's having continuous vomiting, so or he's not cooperative, he's not vitally stable. So all of these, unfortunately, it's contraindication to NIV, so you have to give your patient invasive ventilation in form of mechanical ventilation. So again, upon discharge, most of your patient will be like in moderate exacerbation, or they are stable enough to be discharged. So make sure that they will go out with the prednisolone course again here, 5 days only. You should give them inhaler, but in as we can see here in COPD, usually the form is different. In asthma, it's ICS LABA. In COPD, it's only we are focusing on bronchodilation. So LAMA alone or LAMA LABA combination. So it depends on your facility or the available inhalers in your facility. If you have LABA, you have LABA LAMA, you can give your patient whatever choices you have. طبعا the most common like LAMA or almost the only available in MOH, the tiotropium, Spiriva. LABA LAMA combination, I think we have more than choice, but in MOH also we have Anoro combination of LABA and LAMA. So you just ask your pharmacist about the available options. And also the smoking cessation is here. It's like for smoker patients, it's really make a difference. So if he can stop smoking, symptoms will be improved. He will be at less risk of future exacerbation. I believe that's all. So GINA guidelines, GOT guidelines, they are the most important guidelines in asthma and COPD. And this is the Saudi Thoracic Society guidelines that we are discussing in asthma exacerbation management. That's all. Thank you. Thank you very much. Any questions? Do you have any questions? Food poisoning. Yeah. Now, happy to introduce Reem again. Reem Ahmad is the head of the dental department at the hospital, and also his picture of infections or ID infectious disease consultant, also at our hospital. About present here, she's her second lecture. Actually, today she will be with us for 3 lectures. It's a great effort. So we'll start with the second lecture with the one for food poisoning.
Thank you, Dr. Ahmad. Bismillah ar-Rahman ar-Rahim. Very nice topic, food poisoning. Yes, very common even during Hajj. So I will start with the definition. Food poisoning is an acute illness caused by microorganism facilitated by improper food handling and typical manifesting as gastrointestinal illness, usually happened by the ingestion of food or water contaminated with bacterial or bacterial toxins, viruses, or if your patient is immune compromised, fungal infection or parasitic. Most food poisoning evaluated in ED doesn't need admission, must be self-limited, can be managed with antiemetic and dehydration. Empirical antibiotics may be considered for ill-appearing patients with presentation suggestive this is invasive pathogen. The cause for most of the cases is unclear, up to 80% of cases. Most foodborne illness are secondary to viral illness, viral causes, mostly norovirus, rotavirus, hepatitis A, or adenovirus. Other less common pathogen is the bacterial cause, like Shiga toxin producing E. coli, Shigella, Cyclospora, Yersinia, Listeria, and Vibrio. Salmonella considered are the leading cause of foodborne illness associated with hospitalization and death. There is other two organisms like Listeria, Listeria and C. diff, Clostridium difficile. One of the three organisms can cause death for hospitalized patients. The pathophysiology is when the patient ingested the food containing the pathogen or the spores or the toxin, usually invade and bind and invade the cells and causing cell death. And then patient will manifest with systemic manifestation like fever, bloody diarrhea, and septicemia. Who's as risk factor to get food poisoning? Patient institutionalized persons like in nursing home, prison, military. Daycare exposure, you may find especially viral in daycare. Food handlers, recent foreign travel, they may come with traveler diarrhea, as we call it. Immune compromised patients, they are more prone to get viral or bacterial infection. The history and for the symptoms, the typical presentation, nausea, vomiting, diarrhea, abdominal cramping. If it's invasive pathogen, your patient may present with bloody diarrhea or systemic symptoms. The incubation period depends on the cause and range from a few hours to days. We divide it to three classifications. First is the if the symptoms appear after short incubation period, after ingestion the organism after 1 to 6 hours. Usually this organism is vomiting predominant other than diarrhea. The famous one is the Bacillus cereus toxin. Its toxin can tolerate high temperature. Usually reheating the rice will cause these spores to germinate and producing toxins and cause the vomiting. No treatment needed in such case because it's mainly toxin, only supportive treatment. The second organism is Staphylococcus aureus, gram-positive cocci in cluster. It can range from simple food poisoning to toxic shock syndrome, usually in non-refrigerated or improperly refrigerated meats or potato. Symptoms, as usual, patient will come with nausea, vomiting, abdominal cramps. The treatment is supportive care only, no need to give antibiotic. Usually symptoms will resolve in 24 to 48 hours. The second class is the medium incubation period when the patients present with symptoms after 8 to 16 hours. Also Bacillus cereus here, but usually in this case can present with diarrhea predominant. The second organism is Clostridium bifringis. We know it as it can cause wound infection, but also can cause food poisoning from undercooked meats or home canned foods. Symptoms watery diarrhea, nausea, crampy. Also the treatment is supportive care only. Here is the long incubation period when the patient have symptoms after 6 hours from taking the meal. We have two classifications, either it's toxin producing organism or invasive organism and causing symptoms, and you need to admit this patient. Toxin producing organism, we have 4 types: Clostridium botulism, enterohemorrhagic E. coli, enterotoxigenic E. coli, as we call it traveler diarrhea or Vibrio cholera. The invasive organism, we have Salmonella, Shigella, Campylobacter, Vibrio parahemolytic, Vibrio funnificus, Yersinia, and Listeria. We'll start with toxin-producing organism with the first one, Clostridium botulism. We know this can happen from improper home canned foods, as you can see in the picture. Usually the patient, after this spore germinate in the home canned food, it will act on neuromuscular junction, and your patient will have flaccid paralysis. Your patient will have dysphagia, dysphonia, diplopia, and descending muscle weakness. Usually only supportive treatment here, no antibiotic. You will just need to give antitoxin to eradicate the toxins that circulating in the patient's bloodstream. The second one is enterohemorrhagic E. coli. With this organism, it's mainly undercooked ground beef or unpasteurated milk and contaminated water. The risk factor is daycare center, nursing home, extreme of age. I think most of you know this organism because we try to avoid antibiotic as much as possible with anterior hemorrhagic E. coli because this may increase the risk for hemolytic uremic syndrome. Hemolytic uremic syndrome, it's a hematological disease caused by microangiopathic anemia. Patient has thrombocytopenia and increase in creatinine level. The third organism is enterotoxic E. coli or traveler diarrhea. The source is the food or water from contaminated by human feces. The symptoms is watery diarrhea, abdominal cramp. Generally, it's self-limited, but in this case, you can't give antibiotic because it will shorten the course of illness. Ciprofloxacin, azithromycin is the preferred antibiotic. The fourth of pathogens causing toxin producing is the Vibrio cholera. It's contaminated from water and fish, shellfish, especially food sold by street vendor. Patient will have refuse watery, rice water, diarrhea and vomiting. This strain usually happens because the Vibrio cholera has toxigenic strain. And cholera has the ability to cause both epidemic and pandemic potential and remain endemic in affected area. Now we go to the invasive organism. We started with Salmonella. Salmonella, the food source is contaminated eggs, poultry, chicken, unpasteurized milk, contaminated raw fruits and vegetables. Symptoms as we know it with bloody diarrhea, abdominal cramping, vomiting. For the Salmonella, we prefer not to treat if your patient is immune competent unless there is some criteria or some group of patients you need to treat because they have up to 50% risk to get bacteria with Salmonella, which is a patient with hemoglobin fatigues, patient with ED, patient with steroid. They have the risk of septicemia, so we treat only the patient. We said disease, may lengthen the treatment and will discharge your patient to the community. And he will have to prolong treating and infect, increase the population. Second invasive pathogen is Campylobacter jejuni. Food source is raw, undercooked poultry, unpasteurized milk. Treatment, supportive care only, antibiotic if needed in severe cases or immunocompromised patient, you can give azithromycin. Campylobacter organism colonized after ingestion can colonize the jejunum and ileum, terminal ileum, occasionally extending to the colon and rectum. Third, Shigella, food source is contaminated water, raw produce, uncooked food. Treatment is ciprofloxacin if needed, if the patient immune compromised. We have 4 species for Shigella: dysentery, Flixnari, Bodia, and Sunni. The organism caused bacillary dysentery by invasive mechanism identical to enteroinvasive E. coli. For the Shigella, there is only low inoculum of bacteria can cause infectivity. So if anyone has Shigella or the household members may get infected. Most cases of Shigella are mild, self-limited, so are treated with oral rehydration therapy rather than with antibiotic. Antibiotic may be indicated in severe infection. Vibrio parahemolyticus and Vibrio poniticus, the same food source, usually undercooked or raw seafood. It's a risk factor or presenting severe situation if patient has chronic liver disease. Rehydration is the main intervention for patients with diarrhea, severe infection, require treatment with fluoroquinolone, doxycycline, or third-generation cephalosporin. Antibiotics do not shorten the duration of symptoms. Prevention strategy always the best to involve good food hygiene standards. Yersinia, also food sources beef, undercooked beef or pork, unpasteurized milk. Risk factor with the can cause septicemia in patients with cirrhosis, hemochromatosis, or blood transfusion. Usually supportive care for Yersinia, unless it's severe, then you can give doxycycline combined with aminoglycosides. Listeria monocytogenes, food source unpasteurized, contaminated milk or soft cheese, processed deli meats. Risk factor, concern for pregnant female because if she had gastroenteritis with this organism, it can spread to the bloodstream and cause septicemia. It will get her the risk leading to premature delivery or stillbirth. Immunocompromised patients may develop meningitis and bacteremia. Associated conditions with different pathogens causing gastroenteritis. Botulism, as we said before, if patient can present with symmetrical neurological deficit, change in mental status because of ingestion of the toxins from the spores. Outbreak typically involve home canned foods such as fruits, vegetables, and meats. Hereditary Pyramid syndrome, we mentioned before. Condition characterized by microangiopathic hemolytic anemia, renal impairment, thrombocytopenia, can be caused by Shigella or E. coli, enteric hemorrhagic E. coli. GBS, Guillain-Barré syndrome, ascending paralysis, strongly associated if patient has history of previous gastroenteritis and it was positive for Campylobacter jejuni. Reactive arthritis, it's an immune reaction. Our immune system is supposed to fight the epitope in the pathogen, which is also similar to the epitope in the joints. So this patient have reactive arthritis, must be with invasive pathogens, Salmonella, Shigella, Yersinia, and Campylobacter. This, as I mentioned before, the highest rate of transmissibility in Shigella with 10 inoculum of pathogen. So if anyone in the house member has Shigella, most likely it will spread very fast. For the history, to take deep details from the area to know if this watery or invasive, if this is short inoculum, short incubation or long incubation, to decide which organism it is. Suspect bacterial food poisoning when multiple persons have rapid onset of symptoms after eating the same meal, and patient presents with high fever, blood or nutrition stools, severe abdominal pain, signs of dehydration, recent travel to a foreign country. Further evaluation and treatment with high fever. For physical exam, you will look for any signs of dehydration. If patient has orthostatic hypotension, dry mucous membrane, decreased temperature, if there is delayed capillary refill, or if there is any fever, and also by abdominal examination if there is any peritoneal sign or abdominal pain. For diagnostic test and interpretation, for mild cases, it's self-limiting. We don't need to send for stool culture unless your patient has signs for invasive, like bloody diarrhea or fever. Also for fecal leukocyte or fecal occult blood is not necessary unless your patient showing sign that this pathogen is invasive pathogen. And you will do the basic lab test for CBC, metabolic profile, for severe cases of dehydration. Now the diagnostic approach going for PCR, it's promising. You will have the result in 1 hour, but most of the facility, most likely it's not available in any facility. For the treatment, oral dehydration is the first and most important line of therapy for acute diarrheal illness. Balanced oral rehydrating solution is recommended for elderly or pediatric patients with severe diarrhea, or for traveler diarrhea with severe, or traveler with severe cholera-like watery diarrhea. Most patients with mild illness don't need formal ORS and can rehydrate with fluid and salt-rich foods. Empirical antibiotic is not recommended for most of the cases of acute diarrhea unless it's traveler because it will shorten the course of disease. Consider antibiotic only for patients with severe illness requiring hospitalization and those with fever and hematopoiesia or when diagnostic testing confirm bacterial source. Other additional therapies if the patient has severe nausea, vomiting, you can add for him bromethazine, lubramide if your patient has diarrhea unless it's showing going with enteral invasion. Bismuth subsilate for traveler diarrhea. There is no evidence of effectiveness for prebiotic or probiotic. Hand washing through the course of illness will decrease the spread. Ongoing care, you can advise your patient to drink plenty of water. If the nausea subsided, to start with low-fat plant meat, low-fat meat. Prognosis, most infections are self-limited, resolve over several days. Antibiotic for moderate to severe traveler diarrhea, shorten the duration, as we mentioned. Consider bacterial food poisoning when multiple patients present with fever and bloody diarrhea, ingesting the same food or having recently returned from developing nation. Consider culture and antibiotic if there is persistent fever with blood mucus in stool. Consider concern for sepsis and for symptoms lasting more than 7 days. Withhold any antispasmodic or anti-diarrhea if your patient showing invasive pathogen. Consider empirical antibiotic for traveler diarrhea. In most people with acute watery diarrhea and without recent international travel, empirical antimicrobial is not recommended. Exception is the immunocompromised patients. Avoid empirical treatment if persistent watery diarrhea lasting more than equal 14 days. HUS, we mentioned it before. Prevention, only proper food handling and hand hygiene has been shown to decrease the incidence and transmission of foodborne illness. We can advise our patients when preparing food to wash hands, keep raw meat, poultry away from the salad, wear gloves throughout well-cooked meat, and refrigerate the leftover in 2 hours to 3 hours. When traveling to underdeveloped country, eat only freshly prepared food, avoid beverage and foods prepared with non-potable water. Bottled carbonated boiled beverage are safe to drink. Chemoprophylaxis for traveler diarrhea is recommended only for high-risk traveler, immunocompromised patients. Thank you, everyone.
Any question? I'm happy to introduce you. Very much will talk to us about meningitis. And that's for the theory. The theory is the IT consultant and lieutenant is in the department head at our hospital. So we are happy to hear from you about meningitis.
Thank you, Dr. Ryan. I'm going to talk briefly about this topic because, as we said, in Hajj season with crowded patients, we may have outbreak or we have to concern for how to treat community-acquired acute bacterial meningitis. Meningitis, we know it, it's a serious infection of meninges in the brain or spinal cord. It's caused significant morbidity and mortality worldwide. Case fatality rate from 15 up to 25%. Pathogen depend on age, immune status, or other risk factor. The incidence of bacterial meningitis has declined throughout the year due to vaccine, which altered the epidemiology of community-acquired meningitis. The pathways of infection, most pathogens that cause meningitis colonize the nasopharynx of the upper airway before entering the CNS. Direct infection due to trauma or head surgery. Incubation period for bacterial meningitis usually take from 3 to 7 days. For viral meningitis, from 2 to 14 days. Who's at risk factor to get community-acquired meningitis? Immune-compromised patients are more prone to have meningitis, either if AIDS patient, splenic, heavy alcohol use, crowded occupational or living conditions, close contact with infected person, or patient has congenital deficiencies like C3 or C4 or C5. They are more prone to have meningoxemia. Microbiologist exposed to azulate. This is the host of organism causing adult bacterial meningitis, most commonly Neisseria meningitis, Streptococcus pneumoniae, Haemophilus influenza, Listeria monocytogenes. Other viruses can cause meningitis, like enteroviruses, herpes viruses, mumps virus, arbovirus. For fungal parasitic, unlikely in immune-competent, most likely in immune-compromised patients. I'll start with Neisseria meningitis. It's gram-negative diplococci with 12.0 group. Usually, as we said, patient be colonized nasopharyngeal with Neisseria meningitis. Transmission occur from person to person through droplets, and patients should be considered capable of transmission this organism for up to 24 hours after initiation of effective antimicrobial treatments. We have 5 serogroup of meningitis, thankfully all covered by vaccines. The second cause of community-acquired acute meningitis is pneumococcal meningitis caused by Streptococcus pneumonia organism. It's gram-positive diplococci. More than 90 pneumococcal serotype was identified. Also, the transmission by droplets like Neisseria meningitis. The severity of getting pneumococcal meningitis increased if your patient is immune-compromised, HIV patient, a splenic patient, or has complement deficiency, or have chronic diseases like chronic liver disease, CKD. Pneumococcal meningitis, most commonly etiology of agents, mortality increased up to 26%. Sometimes it's associated with other focus of infection, other severity focus of infection like pneumonia, otitis media, mastitis, sinusitis. The clinical picture, most of you know it, is the classical triad of meningitis with fever, headache, neck stiffness, altered mental status. Around 40 or 50% may present with this clinical triad. Mostly the patient will present with 2 out of 4. Other presentation is photophobia, seizure, nausea, vomiting, hypersensitivity to sound is common. Common symptoms for viral meningitis. Patients may have upper respiratory symptoms preceded by upper respiratory symptoms like sore throat, pharyngitis, hyperangina. By physical examination, you will look for any signs for meningeal irritation by doing neck stiffness, if there is any neck stiffness, or Brzezinski sign. This Brzezinski sign considered positive if your patient has hip flexion while you are flexing the neck. For Kernig sign, if the patient in supine position with extending hip and complain of pain after extension of the knee. You will look also in the examination if there is any signs of increased intracranial pressure by, for example, bubble edema. Other manifestation you may see it in the examination is the cutaneous petechiae, commonly in meningococcal meningitis, and it's suggested for meningoxemia in up to 52% of cases. The patient also may present as Waterhouse syndrome. It's lethal, even with treatment can be deadly. This meningococcal producing a lot of toxins, causing adrenal hemorrhage and causing skin necrosis and coagulopathy. Patient may present with picture like DIC. For laboratory study, we'll do the basic lab for each patient. But if patient suspects meningitis, you need to do blood culture and blood glucose to compare it with CSF glucose. For neuroimaging, it's not necessarily to diagnose meningitis, but you needed to rule out any contraindication to do LB. General approach is the guideline from the IDSA guideline. If you have any patient suspected to have bacterial meningitis, if your patient is immune compromised or has CNS disease, papilledema, or focal neurological symptoms, then you should do CT imaging to rule out any space-confined lesion. Proceeded, you can take blood culture, start empirical therapy, then you will do the CT. You don't delay starting antimicrobial therapy, waiting for the CT to be done. If the patient is not immune compromised, has no focal symptoms or papilledema, you can go for blood culture and doing LB and start therapeutic empirical antimicrobial therapy with dexamethasone. Analysis, the most important data to differentiate between bacterial or viral or aseptic meningitis is the opening pressure. It will be high in bacterial meningitis. For WBCs, for the leukocyte, it will be polymorph, polycytosis mainly in bacterial meningitis, lymphocytic in aseptic or viral or TB meningitis. For glucose in bacterial meningitis, it will be low, and aseptic meningitis can be normal. For TB, you will find it very low. For glucose in CSF, it will be very low. For gram stain and culture, up to 60–90% of bacterial meningitis will be positive. Of course, if you started antibiotic before getting CSF, it may affect the result. It can be negative after receiving antibiotics. PCR now is the promising to define this is bacterial or other organism viral because they are taking the CSF sample and put it in BioFire. You will get the result in 2 hours. Basic management, you should place the patient in sitting position to decrease elevated intracranial pressure. Airway management, especially if your patient came with a low glaucoma scale less than 8, if your patient had seizure, provide hemodynamic support with fluids, vasopressor, identify and reverse any coagulopathy, especially in meningoxemia, identify and treat elevated intracranial pressure. And as we said before, to apply appropriate isolation precaution. Administer empirical antibiotic as soon as possible. Prepare within 1 hour. You don't delay starting antibiotic, waiting for the CT imaging to be done. This is the same what we said before. For the empirical, as we said, the most common organisms, Streptococcus pneumoniae, Haemophilus influenza, and Neisseria. For the antibiotics, they cover, with this regimen, you will cover both organisms. If patient less than 50, they recommend to start vancomycin, 3rd generation cephalosporin. If your patient with age more than 50, you will consider Listeria. So you will add ampicillin to vancomycin and ceftriaxone or 3rd generation cephalosporin. Empirical therapy for viral meningitis. Most cases of viral meningitis is self-limited. No need to add anything except if it's herpes causing encephalitis, and it was suggested by imaging with finding of temporal loop enhancement. Consider hemorrhagic encephalitis if the patient have high RBCs despite non-traumatic LB. Corticosteroid, unlike in community-acquired pneumonia, actually it's very helpful for these patients. It's reduced hearing loss and neurological sequela, but not mortality. Indicated proven for meningitis. If the meningitis is proven to be streptococcus or Haemophilus influenza, then you can start corticosteroid, either concomitant with antibiotic or before giving the antibiotic by 15 minutes. Also, you don't delay starting antibiotic waiting for the steroid if it's not ready. Also, you have to discontinue steroid because it's not proven beneficial for but other pathogens other than streptococcus or Haemophilus influenza. The prognosis, bacterial meningitis is fatal if left untreated. Prognosis in treated patients depend on age, overall condition, and the immune system. For viral meningitis, mostly resolved spontaneously in majority of cases with no residual symptoms. Fungal meningitis, usually in immune compromised, very difficult to treat, and there is neurological sequelae with high mortality, and patients need to be adhere to his antifungal. How to prevent pre-exposure, post-exposure. Pre-exposure, take the vaccine for meningococcal vaccine or Haemophilus influenza vaccine. Post-exposure, as Dr. Ala said before, the post-exposure prophylaxis. These are considered as chemoprophylaxis recommended high-risk group, and you should give chemoprophylaxis group. Patient with household contact with someone positive was positive for meningococcus, child care or preschool, direct exposure to index patient secretions, or healthcare worker during endotracheal intubation. The low risk is the casual contact or indirect contact. These considered low risk, and chemoprophylaxis is not recommended in this group. Meningococcal vaccine, we have 2 vaccines for group B and 3 vaccines and 3 meningococcal vaccine for the other groups. Here is the chemoprophylaxis for Neisseria meningitidis. You have 3 choices, either rifampicin for 2 days, ceftriaxone if your patient is pregnant, or ciprofloxacin, ceftriaxone and cipro, it's 1 dose. For Haemophilus influenza, also there is chemoprophylaxis, considered in unvaccinated household contact. Also only rifampicin, but it will be for 4 days. In this study, they show that mortality for pneumococcal meningitis was decreasing upon time due to vaccine. The complication of adult bacterial meningitis, hearing loss, severe sepsis, stroke, either ischemic or hemorrhagic, brain abscess, subdural emphysema, sinus thrombosis, seizure, shock, and death. In conclusion, most common clinical characteristics of bacterial meningitis are fever, headache, neck stiffness, and altered mental status. In adults with bacterial meningitis, the classic clinical characteristic may be absent, but this doesn't rule out bacterial meningitis. It has been shown that both children and adults, classical characteristic for bacterial meningitis to find high protein, low glucose, CSF shown polycytosis, CSF lactate concentration, good sensitivity and specificity for differentiation between bacterial and aseptic meningitis. CSF culture is positive in 60 to 90% of bacterial meningitis patients, depending on the definition of bacterial meningitis, and if there is any pre-treatment with antibiotic, as pre-treatment will decrease the yield of CSF up to 10 to 20%. Latex agglutination can be helpful. You will have the result in 15 minutes. It will detect the pathogen antigen, but it's not valued. The culture is the background. In adult and children with bacterial meningitis, blood culture is useful to isolate the positive microorganism. The yield of blood culture decreased if the patient pre-treated with antibiotics. In patients with suspected bacterial meningitis, it's strongly recommended to determine CSF leukocyte, protein glucose, and perform CSF culture and gram stem. These are my references. Thank you, everyone. Any questions?
Assalamu alaikum wa rahmatullah. Great to be among these great speakers. Today I'm going to talk about diabetic ketoacidosis, DKA, or hyperosmolar hyperglycemic state, or HHS. The session will be divided into 3 parts: what, why, and how. What is a DKA? Why it happens? And how so is the management. So we start by the definition. DKA is a life-threatening complication of DM. Its characteristics by 2 parts: acidosis and hyperglycemia. The DKA can be defined by the 3 biochemical traits: ketonemia, acidemia, and hyperglycemia. We'll go through the pathophysiology, what happens, what's supposed to happen, and what if it's not. Normally, the pancreas creates the insulin. So the insulin helps the glucose go inside the cell. So insulin is more like a key for the glucose to go inside the cell for energy. This energy creates the glycogenesis, which is the formation of glycogen, and protein synthesis, the formation of protein molecules, and adipogenesis is the formation of fat cells. So what happens if there is insulin deficiency or there is no insulin at all? So the glucose cannot go inside the cells. So the glucose remains in the bloodstream. This leads to hyperglycemia. There is no insulin, so the body burns fat to get energy, and that leads to the creation of ketone bodies, which is acidosis. Here is a comparison between if there is no insulin at all and inadequate level of insulin. There is no insulin at all. This leads to the amount of glucose entering the cell reduced, and the liver creates more glucose This leads to hyperglycemia. Then that leads to osmotic diuresis, which is increased urination. And finally, that leads to dehydration and marked electrolyte loss. If there is inadequate level of insulin, this leads to breakdown of fat into free fatty acids, FFA. This FFA converts into ketone bodies, and that leads to the creation of ketone bodies and leads finally to the metabolic acidosis. Here, I can summarize the causes of DKA in 6 I's: the insulin deficiency, intoxication, infarction, such as MI or CVA, infections, such as UTI or pneumonia, iatrogenic surgeries, for example, and inflammation in the pancreas. So what are the criteria for diagnosis? So the glucose, the blood sugar more than 200. According to the DKA protocol in the MOH is 200. The international literature says 250. But however, as we are in Saudi, we need to stick to the MOH protocol. So it's over 200. The pH level is less than 7.3, and bicarbonate less than 15 mol. Also ketone and ketonuria or ketonuria. DKA can be classified into different levels. There is a mild and moderate and severe, and it depends actually on different societies. So each society might classify it differently, but it depends on Glasgow Coma scale. If it's less than 12, the pH less than 7.1, the ketones more than 6 mol, bicarbonate less than 5 mol, the K level is less than 3.3. The systolic blood pressure less than 90, the SpO2 less than 92%, the urine output less than 0.5 ml. Now we'll go to the signs and symptoms of DKA. This graph summarizes most of the signs and symptoms: a blurred vision, smell of acetone or cosmol breathing, so it's a rapid and fruit breathing, hypotension, tachycardia, vomiting and nausea, polyuria and ketonuria. Now the treatment. First and foremost, it's rehydration. So this is the most important part. Then insulin administration, then the electrolytes balance, mainly potassium. I will go through these 3 in details. So DKA patients comes with a different level of dehydration. So hydration is very important, yet we need to introduce it or initiate it carefully and with well monitoring, because we will start with NS, 15 to 20 ml per kg, or 1 to 1.5 liter during the first hour. Further fluid replacement depends on the physician and the hydration status and the acidosis. Quick and over replacement of fluid can be risky. Why? Because it might lead to cerebral edema. So we need to be careful when we are giving fluid. The amount of fluid needs to be well monitored. For insulin, initiate 1.0.1 IV insulin. Then we can lower the dose, depends on the blood sugar. Then later we can switch it from IV to subcutaneous insulin. So when the blood sugar falls below 72, then we can give D5. Some of you might think, well, why do we need to give a dextrose if the patient is already hyperglycemic? Well, we need to monitor the slowdown of the high blood pressure. It needs to go down. Think of it as an airplane. The airplane is the hyperglycemia. When it goes down, the airplane needs to slow down until it lands to the ground. So if the airplane crashes very quickly to the ground, it's going to crash. So the same thing with the blood sugars, need to go down slowly. Insulin is given when the serum potassium level is more than 3.3. So what if the K level is less than 3.3? Can we give up insulin? Well, first we need to give potassium, then we can start insulin. When the K level is less than 3.3, give potassium, then we can start insulin. That is to help us to prevent hypokalemia, which is arrhythmia and respiratory muscle weaknesses. For potassium therapy, insulin therapy, correction of acidosis, volume expansions, decrease the volume of potassium. So that leads to hypokalemia. Also, patients with severe vomiting or who had been on diuretics, also that they would present with significant hypokalemia. Well, to prevent that, potassium should be initiated after serum level below the upper level or the limit of normal, which is 3.5. Sorry. Bicarbonate is not a common thing, but we only give it in a severe acidosis, pH less than 6.9. If a pH is less than 0.9, then we give bicarbonate 5 ml, dilute in 200 ml. Repeat bicarbonate infusion every 2 hours until pH is more than 6.9. Monitor K level every 2 hours while on bicarbonate sodium. For a hyperosmolar hyperglycemic state, or HHS, HHS is characterized by two things: severe hyperglycemia and severe dehydration, or hyperosmolarity, and the absence of ketoacidosis. There is no ketones with the HHS. Why? Because there is already insulin in the body, so the body does not need to burn fat, and that does not create the ketones. Most cases with HHS are seen in elderly patients with type 2 disease. As I said, with type 2 disease, there is a little bit of insulin which the body can use for energy and doesn't have to use the fat. There's a comparison between the two, between DKA and HHS. For the DKA, it's kind of the same letters, DKAA, dry and high sugar from 250 to 500. Ketones cause more risk, which is the rapid fruit respiration, abdominal pain, which doesn't happen in HHS, and acidosis, pH less than 7.3. For the HHS, it's a severe hyperglycemia, more than 600, severe dehydration, no abdominal pain, no acid, that means no causal risk, and slower onset and with stable potassium. Patients with HHS may present with confusion, coma, seizure, vomiting. Precipitating factors include diagnosis of T2, type 2 DM, infection, high doses steroids, MI, vomiting, and stroke. Physical examination include dehydration. We can check the patient's skin trigger, and we can see the cracks on the patient's lips. So that indicates dehydration, hypotension, coma, confusion, and features of the precipitating factors. For HHS management, it's always hydration. It's always start with NS IV fluid. Make sure the patient has intact ABC and support is indicated. Cardiac monitor is important, especially if we are giving potassium, because potassium might lead to arrhythmia. Urinary catheter. Consider central venous pressure and nasogastric tube if there is a necessity. The goal for treatment of HHS, treating the underlying cause, gradually and safely normalize the plasma osmolality, replace fluid and electrolytes, normalize blood pressure or blood glucose, Other goals include prevention of cerebral edema, as we said. This table also summarizes the comparison between DKA and HHS. As we said, DKA more common in type 1 DM. HHS is more common with type 2. Mortality rate relatively lower in DKA, relatively higher with HHS. Presentation abdominal pain, as I said, it means it's a DKA rather than HHS. Fatigue, altered of consciousness, confusion. This is also indicates HHS. The onset DKA starts quite quickly, within hours, while the HHS might take days. The glucose criteria, as we said, the glucose for DKA is more than between 250 to 500, with the HHS is more than 600. For the management, it's always fluid replacement, and also treating the precipitating factors, potassium replacement. And thank you very much. This is the resources. And here is a barcode for the DKA protocol from the MHS. If you want to scan it, that takes you to the protocol. Shukran.
السلام عليكم. دحين بريك حسب الجدول. نلقاكم إن شاء الله بعد البريك بإذن الله.
again. I think that is not Rich, as he is presenting that important picture. And he is one of the visionary department. Our fifth speaker is Dr. Abdul Malik. Dr. Malik he is a biologist, he is a physiologist in Alabama University. He will talk to you about the myocardial infarction and the role of transfer through MRH.
This one is ما حيأثر. السلام عليكم. أهلا وسهلا. إن شاء الله نفيد ونستفيد إن شاء الله في المحاضرة هذه. Our topic is myocardial infarction. First, we will start with the definition. So we have two terms we have to know it. That is the unstable angina, which is the myocardial ischemia at rest or on minimal exertion in the absence of acute myocardial necrosis. Myocardial infarction is cardiomyocyte necrosis in the clinical setting consistent with acute ischemia. Clinical setting means there is chest pain, there is ECG changes, there is biochemical markers elevations, and also the imaging modality that confirm there is myocardial injury. Epidemiology. The overall prevalence of coronary artery disease in Saudi Arabia is 5.5%, and usually the patient population usually is 10 years younger than that compared to the worldwide population. 38% and in some resources 55% of heart failure in the Middle East are attributed to coronary artery disease. This is our population in Mecca, regular population, almost 2.3 million. And usually the pilgrims, they are almost around these figures or more. As expected this year, maybe more than that. This is the number of pilgrims in the pre-COVID time. It's almost the same as Mecca population. What we noticed that it is doubling the population of Mecca with a high risk of population. Usually the pilgrims, they are old age, they are at least moderate to high risk population. Pathophysiology. We have 4 stages of ischemia to necrosis or infarction. It starts first with the stable angina, and there is a progression of atherosclerotic plaque over months or years, resulting in stenosis that will result clinically in chest pain with heavy exertion. Then this plaque sometimes it gets ruptured, resulting in 2 or 3 forms of ACS. The first one is there is a plaque ruptures with almost partial occlusion of the coronary artery disease. There is a flow, but there is no necrosis, no myocardial damage. So this, there is no troponin leak. So this is unstable angina. Sometimes the partial occlusion become more severe, resulting in more endocardial damage, which is result in myocardial necrosis in the endocardial area. And this is what we call it non-STEMI. There will be the difference between non-STEMI and unstable angina. Both of them, there will be black ruptures, but in the unstable angina, there will be no myocardial damage, while in the non-STEMI, there will be endocardial damage. In STEMI, there is complete occlusion, acute complete occlusion of the coronary artery, resulting in the transmural or full thickness of myocardial damage. Type of myocardial infarction. We have 5 types of myocardial infarction. The first one is type 1 myocardial infarction, which is MI related to atherosclerotic plaque rupture, ulceration, fissure or erosion, with resulting intraluminal thrombus in one or more coronary artery disease, leading to decrease in myocardial blood flow. Type 2 myocardial infarction is that related to imbalance between demand and supply. Usually, the conflict with the medical cases is it myocardial infarction? Is it related to the underlying condition, sepsis? Is what we call it is type 2 MI. This type is including the decreased blood supply in the form of hypotension, bradycardia, hypoxia, and anemia, or it could be related to increased demand, which is hypertension, emergency, and tachyarrhythmia. This type also includes the other form of, other than atherosclerotic form, like coronary artery spasm or coronary artery dissection, also included in this type. Type 3 is the MI related resulting in death. Usually, either the patient will complain of chest pain before the episode, or there is an autopsy confirmed there is a myocardial damage. Type 4 is MI related to BCI, and type 5 related to CABG. Risk factors. There is as all atherosclerotic risk factors, it including modifiable, non-modifiable risk factors, and modifiable one. The age is the predictor or the main predictor. Even in the risk stratification, the age get high points in all these. Gender, male has predominance of risk factors, family history of coronary artery disease, past history of coronary artery disease, and ethnicity. The modifiable risk factor, which we can try to control it during hospital stay and also after discharge in the OBD. And this includes diabetes, hypertension, dyslipidemia, and to change lifestyle in form of sedentary lifestyle and smoking cessation. And also depression we have to treat in addition, and also obesity we have to manage it. Typical symptoms, it usually present, as we know, with retrosternal chest pain, usually associated with shortness of breath, diaphoresis, nausea, vomiting, and palpitations, sometimes with lightheadedness. Some cases, like in case of inferior MI, and in case of in elderly and in the women, usually they present with atypical symptoms, including dyspnea and GI upset, including nausea, vomiting, and epigastric pain. Physical examination, usually in the ACS, usually is normal physical examination, but sometimes we will find signs of ischemia, which including S4, new murmur related to papillary muscle dysfunction, paradoxical S2. Usually, sometimes we find sign of heart failure, which including the elevated JV pressure, crackles in the lung, S3, hypotension, cold extremity, and sometimes we find sign of vascular disease, including asymmetrical blood pressure, radial delay or radiofemoral delay, carotid or femoral fluid, and decreased distal pulse. ECG is our cross point in the treatment of acute coronary syndrome. ECG has to be performed within 10 minutes of presentation with the symptoms. Usually, in case of normal ECG, we have to proceed for posterior lead ECG, looking for, as sometimes the left circ infarction results will not present in the routine ECG. Sometimes we have to do the right side ECG just to confirm if there is RV infarction or not, because it will help in the future of management plan. When we have to repeat the ECG, we have to repeat it if the initial ECG was negative. And in this form, we have to do it every 15 to 30 minutes in the first 1 hour. And also we have to repeat for any changes of the symptoms, even if the initial ECG there is a significant changes. So if any changes of the symptoms, we have to repeat the ECG. As it may progress to STEMI. Sometimes STEMI will progress to STEMI form. So we have to give time for the ECG for diagnosis, as the one who first observed the ECG, the other will follow him. So rarely we saw, but it is happen. Patient present with STEMI, and it didn't discover till the second set of troponin, which is almost 4 hours past while he's in ER. So we have to give it time for ECG just to decide which track we have to go through. Criteria for STEMI diagnosis: we have to have ST elevation in two or more contiguous lead. Usually we need 1 millimeter ST elevation, but in V2 and V3 we need 2 millimeter in men and 1.5 millimeter in women. If we do the posterior lead ECG, we need only 0.5 millimeter ST elevation to diagnose that. Criteria for diagnosis of STEMI in left bundle or ventricular pacing. Usually, if the patient present with chest pain and left bundle, usually we consider that as STEMI equivalent, and we will activate the cath lab based on that. If the presentation is not typical, so we have Scarposa criteria that we can use it for diagnosis of STEMI in left bundle and also in the ventricular pacing rhythm, as it will be wide QRS complex. And this includes ST elevation in more than 1 millimeter, concordant with the direction of QRS, or ST elevation of more than 5 millimeter, discordant with the QRS, or ST depression more than 1 millimeter in V1 to V3. Other sign of ischemia, it includes ST depression more than 0.5 millimeter, or T-wave inversion more than 2 millimeter, or hyperacute T-wave. Q-wave or poor R-wave progression may suggest prior MI. Other point that Q-wave have nothing to do with the time of intervention, that if the patient present with STEMI and there is a Q-wave, we have not neglect that Q-wave, and the time will be as usual. The 12-hour will be secured based on the patient's complaint of chest pain. The biochemical markers, we have to do the routine lab works to look for the risk of intervention. The other point to rule out, as we mentioned before, type 2 MI. CBC looking for hemoglobin, renal profile, looking for creatinine and electrolyte disturbance. Liver function test, coagulation profile. Serial troponin, we used to do it at the presentation. If it is positive with this presentation, that's fine. Otherwise, we have to do we have to repeat it after 1 or 2 hours. And there is a specific algorithm for that, looking for significant changes. Sorry. Okay. As we mentioned, the serial troponin, we have to repeat it upon presentations, and we have to repeat it 1 to 2 hours. And for significant changes, there is a specific algorithm for every kit for troponin. PMP and in-terminal pro-PMP we use for prognostic issues. Lipid profile, hemoglobin A1C, and thyroid function test for risk factor modifications. Echo we used to do it for all patients who have moderate to high risk of high suspicious of coronary artery disease. Also, we have to do echo immediately after the ECG in case of cardiac arrest or hemodynamic instability, and the cardiac issues is not clear for that. So we better to do the echo, looking for any regionality, confirming the diagnosis. Echo have to be repeated if any change of the patient clinical status. Other workup, usually for the low and moderate risk patient, we used to do this stratification for further stratification of the patient. Exercise test, stress test, we use it for the low risk patient. Exercise or dobutamine stress echo, and myocardial perfusion imaging, cardiac CT, and cardiac MRI for the moderate and sometimes in low risk patients, rarely in low risk patients. The initial management for all cases of ACS start with our pillar of aspirin, loading dose of 162 and or 325, usually crushed to make more rapid action of aspirin. Then after that, we are giving it 81 milligram daily. We have to choose, in addition to aspirin, one of the B2Y12 inhibitors, including ticagrelor, prasugrel, and clopidogrel. In case of non-STEMI and in case of non-STEMI and case of STEMI, we prefer ticagrelor and prasugrel over clopidogrel. The other prasugrel we use to give it in case of if we plan to do BCI. Otherwise, we have not to give it. Okay, and we have to be cautious if the patient age above 75 or if the weight of the patient is less than 60 kg. In the brief, for clopidogrel is the only medication that use it in the fibrinolytic treatment. And usually if the age for the patient above 75, we have not to give loading dose, only regular routine dose. Plus this, we can give as a pre-cath, and this is more invasive, to give GB2B, 3A inhibitors in case of indicated there. Anticoagulation, we have it to give it for all patients. And this is usually unfractionated heparin. The dose will be 660 units per kg IV bolus and then infusion to be titrated based on the BTT. Enoxaparin, other choice is in the lytic therapy, we have to give 30 milligram IV bolus, then 1 milligram per kg BID. And in BCI cases, we have to give 0.5 milligram per kg IV bolus. Bivalirudin, usually we give it in case of heparin-induced thrombocytopenia, which is the contraindication for heparin use. And the dose will be 0.75 milligram per kg IV bolus, and then infusion 1.75 milligram per kg per hour. Fundiparanox, usually in the case of conservative management and no plan for intervention, we give it as it is associated with high risk of thrombosis in the stent thrombosis if we give it in pre-cath time. Other anti-ischemic medications and anti-failure, we have to give it according to the indications. Beta blocker, sometimes we need to give it orally. Usually we are giving it orally, but sometimes we're giving it IV in case of hypertension with no contraindication and no sign of heart failure. ACE inhibitors and ARB or interestobase if there is a heart failure or if there is diabetes, nitrate if there is ischemia or still chest pain. Other anti-failure treatment including spironolactone, empagliflozin, ivabradine, Lasix. Also high dose of statin. If not controlled lipid profile, we can add ezetimibe and PCSK9. BBI as a gastric protection. So if the patient present with chest pain, so from the ECG, we either go to the STEMI track or to the non-STEMI track. in the non-STEMI track, we have a pathway there, fast pathway. In the non-STEMI track, we have to stratify the patient based on the risk stratification score. As the time is passed, the muscle is lost. So time is muscle with the STEMI cases. So the first presentation of the patient with chest pain, and he will have first medical contact. The first medical contact is either in the The first medical contact of chest pain is either the ambulance or in the ER in the hospital. So we have to do in both, in these cases, we have to do ECG within 10 minutes and interpret it within 10 minutes. Okay, in case of STEMI diagnosis, we have to give time for that because as I mentioned before, is once you say there is no STEMI, no one will look for the ECG till after the second set of troponin, which is will be too late for that. If the patient presents to BCI capable center, so we have to shift the patient within 60 minutes and to the cath lab and to do BCI for that. If the patient is present to non-BCI capable center, the treatment depends on the duration of transfer. If the time of transfer more than 120 minutes from the diagnosis of STEMI, we have to, if it is more than 120 minutes, we have to proceed for thrombolytic therapy. In this situation, usually thrombolytic more benefit of thrombolytic within 2 hours of presentation. That's why if there is a more delay for that, there will be more risk for the patient. So better to give thrombolytic. And then after thrombolytic, we can transfer the patient within 2 hours to 24 hours if there is no indication for immediate intervention. If the transfer duration to BCI capable center is less than 120 minutes, we can transfer the patient to primary BCI, and this has to be while crossing the obstruction within 90 minutes of presentation of diagnosis. Sorry. This is the same as we mentioned. This is our complex, our cluster pathway. Macca cluster pathway is not a complex, almost the same as we mentioned before, but it's include different situations like community situation, how to deal with primary care, secondary care, and the BCI capable center. So almost the same as we mentioned before. Transfer to KMC Mecca. Usually we have 2 hotlines. First one, including KMC hotline, direct with the interventionist and cardiologist in KMC. And usually they have a number that is available in all ER centers. KMC we have to contact only in case of STEMI, and also in case of non-STEMI if there is indication for immediate intervention. And we will go to that in the next slide. In case of life-threatening cases other than STEMI and non-STEMI, like aortic dissection, unstable infective endocarditis, or valve issues, we can contact the MOH hotline and we can transfer the patient to the tertiary center, KMC. If the patient is stable, non-STEMI with no high-risk features, or the patient is low risk or moderate risk ACS, we can use HALATI for urgent or routine transfer. Prognosis. For the STEMI cases, we have this TIMI risk score for prognosis, and this will assess the mortality within 30 days. And as we noticed that the age is the most predictor, that giving 2 to 3 points if the age is more than 75. Other hemodynamic issues, including Calypso class. And this is Calypso class is the how much pulmonary edema is there. Class 1, usually there is no lung crepitations. Class 2, there is mild basal crepitation. Class 3, there is pulmonary edema. Class 4 is cardiogenic shock. And in addition to anterior remi has worse prognosis. If there is more risk factor, there is worse prognosis. If the weight is low, also it's a worse prognosis. And the time of the intervention is also, as long as it gets longer, it gets more worse prognosis. The medication, as we mentioned before, it's aspirin, prasugrel, ticagrelor, or clopidogrel. Prasugrel and ticagrelor is preferred over clopidogrel. Heparin, enoxaparin, and bivalirudin. Here, fundibarinox is not preferred because there is increased risk of instant thrombosis. Also, we have to use high dose of statin, beta blocker, ACE inhibitors, and nitrate based on the indications. In fibrinolytic, the medication for that is including the same aspirin, okay. And if you want to give fibrinolytic, the only medication that B2Y12 inhibitor is the clopidogrel. No ticagrelor and no prasugrel. Okay. And usually clopidogrel, if the age above 75, we have not to give loading dose, only regular dose. We can use heparin infusion, we can use enoxaparin, IV, then subcutaneous. The heparin for 48 hours and or till BCI, and enoxaparin usually up to 8 days for till BCI. The same medication, other medication for that, statin, beta blocker, ACE inhibitors, and nitrate based on the indication. Contraindications for fibrinolytic is include absolute contraindication for that is the previous intracranial hemorrhage, ischemic stroke in the preceding 6 months, central nervous system damage or neoplasm or AV malformation, recent major trauma, surgery or head injury within the last month, GI bleeding within the last month, non-bleeding disorders, excluding menses from that, and aortic dissection, and non-compressible puncture site like liver in the last 24 hours, like liver biopsy or lumbar puncture. The relative contraindication is the transient ischemic attack in the preceding 6 months, oral anticoagulation therapy, pregnancy, or within 1 week postpartum, refractory hypertension, advanced liver disease, infective endocarditis, active peptic ulcer disease, prolonged or traumatic resuscitation. Dose of fibrinolytic, streptokinase. Okay, streptokinase, now rarely used. Alteplase, it has a bolus dose and then infusion over 90 minutes, 2 doses, 30 minutes, and then 60 minutes. Ritaplase, it has 2 boluses doses, 30 minutes in between. Tenecteplase is a single dose bolus. For the tenecteplase, we have, if the age above 75, we have to give half dose of tenecteplase. How do we know that we have successful thrombolytic? If the chest pain resolve, or and if there is more than 50% ST elevation resolution after 16 to 90 minutes. What we have to do in case of failed fibrinolytic, no rule of free administration of lytic therapy. So in this case, we have to transfer to rescue BCI and contact the KMC for that. So what's the indication for transfer or immediate transfer? If there is hemodynamic instability, in case of thrombolytic, if there is hemodynamic instability or heart failure, we have to transfer the patient immediately for rescue BCI. Also, if there is failed fibrinolytic therapy, or if there is evidence of re-occlusion after successful lytic therapy, and all patients of post-thrombolytic therapy, we have to transfer within 2 to 24 hours. Second is the non-STEMI or unstable angina. In these cases, sometimes the patient hemodynamically unstable. This is we have to transfer immediately. But usually low or moderate risk patient, we have to certify them based on the risk score and decide what modality of management we have to go through, either invasive or conservative management. The best is the GRACE risk score, which including risk in hospital risk score and 6-month risk score assessment of mortality. Usually the risk if above 109, this is moderate risk. If it is above 140, this is high risk for high risk in non-STEMI. This is the curve. If we saw that this is the risk of mortality, predicted mortality, and as we saw that on 110 GRACE risk score, we saw that there is increase in the mortality risk. And at 140, almost the descent is very vertical. Other simple risk score, which is TIMI risk score, which is including this risk score, and 3 or more, it make the patient high risk for mortality within 14 days of presentation. The medications for the non-STEMI or unstable almost the same. That aspirin, but here, if we want to proceed for invasive, we have to use prasugrel. Otherwise, if we want to plan for conservative management, better not to use it. Use the ticagrelor or clopidogrel. Time of invasive strategy in the non-STEMI cases. Usually, if there is hemodynamic, if we diagnose a patient with non-STEMI and there is cardiogenic shock or hemodynamic instability, we have to transfer the patient immediately within 2 hours. Okay. If there is a refractory angina or also if there is a electrical instability, we have also to transfer the patient within 2 hours for urgent PCI. If there is high risk features, like we mentioned that if the TIMI score more than 3 or if the GRACE risk score more than 140, we have to transfer the patient within 24 hours. Otherwise, in the other low risk patient, we can do BCI before discharge. So this is as I mentioned, the immediate invasive strategy within 2 hours is indicated in hemodynamic unstable patient or in case of cardiogenic shock, recurrent or refractory chest pain to medical therapy. If there is life-threatening arrhythmia, if there is mechanical complications, or if there is heart failure related to non-STEMI, or if there is a ST depression and more than 6 leads, with ST elevation in 1 lead, including the ABR or V1. Early invasive strategy to transfer within 24 hours, including any patient with established non-STEMI. If there is a dynamic ST changes, if there is a transient ST segment elevation, or if the risk score of GRACE is more than 140. Dual antiplatelet therapy duration. It's a benefit risk between the bleeding and ischemic risk. Those patients have a high risk for ischemic insult, including any patient with complex coronary artery disease with at least diabetes, recurrent MI, any multi-coronary artery disease, or polyvascular disease, or premature or accelerated coronary artery disease. Also, the systemic inflammatory disease is a risk factors for high ischemic insult and CKD finally. Dual antiplatelet duration, it depends on the bleeding risk, as we mentioned, and the ischemic risk as well. So the bleeding risk, we are doing it upon admission, and based on that, we will see if the patient is high risk of bleeding or not. This is a precise DAPT score, and this score will assess the risk of bleeding. We usually do it upon admission to look for if we need to shorten the duration of dual antiplatelet, 3 to 6 months. Usually dual antiplatelet, the standard is 12 months. To shorten it to 3 to 6 months if there is high risk of bleeding. And this if the precise DAPT score is above 25. So in this case, we have to shorten it to 3 to 6 months. After 1 year of a dual antiplatelet with uneventful episodes, we have to assess the ischemic risk by DAPT score. If the DAPT score 2 or more, in this case, we prefer to prolong the duration of antiplatelet after 1 year. This is the illustration of what we said, that if the patient is very high risk bleeding, usually the indication of intervention rare, is not common to do it, but in special situation, we are doing it. In very high risk of bleeding, 1 month of dual antiplatelet, aspirin, and clopidogrel. And then after 1 month, we can continue only clopidogrel. This is very high risk patient of bleeding. In the high risk bleeding score that, as we mentioned, the precise DAPT risk score of more than 25, we can continue as a class 2A, the dual antiplatelet aspirin and clopidogrel from 3 to 6 months, and then after that we will continue only aspirin. Usually in the high risk of bleeding, we avoid prasugrel and we avoid ticagrelor. In a low risk patient, we usually give a standard dose of dual antiplatelet for 1 year. Okay, aspirin or Lavix or prasugrel, aspirin or ticagrelor, aspirin or and clopidogrel. To extend the duration of treatment beyond that is dependent on the DAPT score, which is assess the risk of ischemia. Some patients with AFib will need anticoagulation in addition to dual antiplatelet therapy. And in those patients, usually the strategy is for triple therapy, oral anticoagulation plus dual antiplatelet for 1 week, and then to continue on double therapy, oral anticoagulation and single antiplatelet for 1 year, and then after 1 year we will continue orally on oral anticoagulation. In high-risk bleeding patients, usually also we will continue triple therapy, including oral anticoagulation, dual antiplatelet for 1 week, and then for 3 to 6 months, we use double therapy, new oral anticoagulation, and single antiplatelet. And then after 6 months, we continue only on oral anticoagulation. If the patient is high risk of bleeding, triple therapy will continue up to 1 month. Okay, and then we will, after 1 month, we will continue for 1 year double therapy, including oral anticoagulation and single antiplatelet. Complication of MI in general, including cardiogenic shock, heart failure, mechanical complication, including free wall rupture, ventricular septal defect, or papillary muscle rupture. And this situation where the patient will be unstable and sometimes need urgent surgery. Arrhythmia, VT, ventricular tachycardia, or ventricular fibrillation, or complete heart block. Another issue, sometimes the late presentation, is LV thrombus, ventricular aneurysm, pseudoaneurysm, or pericarditis. Thank you. Any question?
for your informative talk. Thank you. Um, 5 minutes, 10 minutes to review our speakers.
هذا اللي عندك. طب تبدا بهذا الدكتور.
emergency department. Welcome to Dr.
هذا الزوم هذا نقول الاونلاين احنا عاملين فيرشوال. هذا هو امسكوا هذا الجهاز. بس اشيلهم كذا احطه بجيبي. يعلق له هو اي خلاص. انا في صوت انا طفيته. ما طفيته؟ عشان بيطلع صوت.
Assalamu alaikum wa rahmatullah. Thank you for the invitation. I know it's been a long day for you guys, and I hope I'm going to be short and to the point. طيب, in regards to strokes in the emergency room, كيف الصوت واضح؟ طيب. In regards to how to manage stroke patients in the ED, I'll use it when I need it. استخدمه لما خلاص ماشي. طيب, how do we manage stroke patients in the ED? طبعا, the talk has 45 slides or so. I'm going to start with the most important points. I'm going to give you the bullets, the takeaway messages from the talk. And then I'm going to speak about the details. So in case if I lost you, at least you have the important stuff. Stroke management. Before 1995 was basically supportive management. So all what we did is admit patients and manage complications, give laxatives, painkillers, treat infections, and so forth. In 1995, the NINS trial came out and approved the use of intravenous TPA, or tissue plasminogen activator, to treat patients presenting with acute strokes who present within 3 hours of symptoms onset. And then in 2009, this window period was extended to 4.5 hours. And in 2015, endovascular mechanical thrombectomy treatment was approved. And it's since then, it's been a revolution. If you compare management before 1995 and now, it's a huge leap in the management of acute strokes. However, a lot of patients who present to our hospitals, they don't receive the proper treatments. And the reason is because the treatment of acute strokes is very time sensitive, which means that the earlier you deliver the treatment, the better the outcome. Our problem is in most institutes, we don't have a protocol. We don't have guidelines to follow when you have patients with acute strokes. If we compare ourselves to cardiologists, we're 50 years behind. Because if you look, cardiologists have been intervening and treating heart attacks emergently, and they have protocols and pathways for the last 50 years. Neurologists lag 50 years behind. That's one thing. The second thing is neurology or acute stroke patients, they usually don't complain. They don't complain. They're aphasic, they're weak, and they don't want to come to the hospital, which is different than a cardiac patient who is in severe pain. He wants to come, he wants to receive treatment. these 2 points probably help in not delivering the treatment in a timely fashion. And the reason we say treatment of acute stroke is time sensitive is because every minute that passes by without reperfusion, 2 million neuron dies. This has been calculated in vitro. And functionally wise, every hour that passes without perfusion, the brain ages 3.6 years every hour. So there's a misconception when managing acute strokes. I know our emergency room doctors, they know that the window period for IV TPA is 4.5 hours. So when the patient presents to the ER, let's say 1 hour after symptom onset, that does not mean you have 2.5 hours to deliver the medication. So it doesn't mean that you take your time. It doesn't mean that you get relaxed. It doesn't mean that you take your cup of coffee. Why? Because we know from data that the earlier you deliver the TPA, the better the outcome. And I'll show you later on the TPA graph, the difference between those patients who received TPA within 3 hours and those who received it beyond 3 hours. The number needed to treat is it's almost doubled if you delay the treatment by 1 hour. So time is brain. Bottom line, time is brain. Same thing about mechanical thrombectomy. Mechanical thrombectomy is a very effective modality in treating stroke patients. Again, it is time sensitive. Recently, we've learned that actually some acute stroke patients with large vessel occlusion means occlusion of the terminal ICA, internal carotid artery, or middle cerebral artery, or ACA or PCA. These patients can be a candidate for mechanical thrombectomy up to 24 hours. So the bottom line here, what I'm trying to say, since we're talking about time is brain, any patient who comes into the ER with stroke symptoms, we're going to talk about the stroke symptoms soon. Any patient who comes to the ER with stroke symptoms within 24 hours, I would classify this as code stroke. Well, this is very important. I don't want people to say, well, he's at 5 hours symptoms of onset, I'm not going to do anything. Any patient who presents, this is the biggest key message here. Patients who present with acute strokes within 24 hours, this is a code stroke, period. So the emergency room doctor, nursing staff, radiologists, radiology techs, neurologists, they all have to be on board to treat or to deal with patients who present with acute stroke within 24 hours. So if he's out of the TPA window, that does not mean that there's nothing to be done, because we can still treat the patient if he or she had a large vessel occlusion. Number 3, acute stroke treatment is a collaborative work. It's a teamwork. It's not the neurologist duty. It's not the ER physician duty alone. It's the ER physician, it's the ER nursing, it's the radiologist, it's the radiology tech, it's the neurologist. So it's a collaborative work. And if all these personnel did not work together to achieve the goal, then we're going to have a problem, because the only way think about it like it's a heart attack. There's a pathway, there's a protocol for the same reason. It's not so the cardiologist comes into play in a single part, but if the ER doctor, if the ER nursing, if the techs, if the in-house internist or cardiologist are not working together, the treatment is not going to be delivered in a timely fashion. So the last point is we have to understand that the treatment of stroke is collaborative work. It's a teamwork. These are the most important 3 points I have in my talk. The rest is details. So the first is that in the past, we did not use to treat strokes. Now we can change lives. Bi'amrillah. Ithnain, treatment of acute stroke is time sensitive. If the patient presents within 1 hour, that does not mean I have 2.5 hours to take actions. No, the earlier, the better. واضح. Number 3, teamwork. طيب. So stroke, as almost everybody knows, it's a very common problem. Incidence in Saudi is almost 57 patients per 100,000. Over the next 10 years, we expect the incidence of stroke to skyrocket to 60% because our population is young and they're going to age. So the incidence is going to jump. The other problem is stroke is the second leading cause of death and number 1 cause of disability. Not in Saudi, the whole world. So in addition to the social burden, there's an economic burden. So the earlier you deliver the treatment, the less likely the functional disability. How do we classify strokes? The purpose of this talk is to talk about ischemic strokes, which is the majority of strokes. 85% of acute neurologic deficits are related to ischemic strokes. 15%, the remaining 15% is related to intracranial hemorrhage or subarachnoid hemorrhage. For the sake of this talk, we're going to focus on ischemic stroke. This is the algorithm. This is the suggested algorithm. This is what everybody or every hospital should have. And I have no problem with every hospital having their own guidelines or their own protocol, as long as we achieve the ultimate goal, which is to achieve reperfusion in a timely fashion. The way we think about this, when ideally in the ideal world, the hyperacute treatment of strokes starts with EMS. EMS notifying our emergency room doctor, saying that we have a stroke patients with stroke symptoms coming to your ER very soon. So everybody gets ready, right? The ER, the radiology tech, the radiologist on board, everybody's ready to receive the patient. So with the first 10 minutes is basically stabilizing the patients, assessing the patients, connect the patient to monitor, get an ECG, send blood work, make sure the patient is stable. Within the first 10 minutes, neurologist should be called. Let's say a patient came into the emergency room door. The ER physician assessed for 10 minutes, come up with an assessment, called the neurologist immediately. So the neurologist should be at the bedside within 15 minutes. And then after that, after the neurology assessment, patient should be sent to the scanner after all the initial workup, the basic workup has been done. The CT scan, the basic non-contrast CT scan should be done within 25 minutes. 25 minutes. To make it simple, if the patient is presenting within the TPA treatment window, which is 4.5 hours, and the CT scan is negative for bleeding, and the patient does not have any contraindication to TPA, we should ask the pharmacist to mix TPA and get it ready to be given. And what we should do is we give the bolus, wait for the infusion, get a CT angio scan to look at the blood vessels to see if there's any large vessel occlusion, then get the patient out, continue the infusion, and then look at the CT angio. If the CT angio showed large vessel occlusion, you can, if your institute does not have the service to provide, then you should communicate with your center for an immediate life-saving transfer. So if you think about the 4 scenarios of treating stroke patients, you can give TPA and perform thrombectomy, okay? Or in another scenario, you can give TPA because the patient presented within 4.5 hours, but do not perform thrombectomy because the patient does not have large vessel occlusion. Scenario 3, you cannot give TPA because the patient is out of the window or has contraindication to TPA, but you still can do mechanical thrombectomy because the patient has large vessel occlusion within 24 hours. Or you cannot do either, no TPA or no thrombectomy for whatever reason. So these are the ultimate 4 scenarios in treating acute stroke patients. So keep it in mind. having an algorithm always makes it easy to follow through. When it becomes a habit, time wasted gets less and less and less. So the goal is to give, if the patient is candidate for TPA, is to give TPA within 30 minutes. If the patient is candidate for mechanical thrombectomy, a dose to needle should be within 60 minutes. Okay. So what are the clinical manifestations? So this is very important to us, EMS people, ER doc, family too. What are the acute stroke symptoms? Any acute neurologic deficits, by definition, could be strokes. And for simplification, BFAST is the mnemonic to remember those symptoms. So imbalance, blurry vision, face asymmetry, weakness in the arms, speech difficulty or language, or so forth. T for time. What are the symptoms for cortical signs, which could eventually indicate large vessel occlusion? And it's very important for emergency room doctors, for EMS to recognize this, because if the patient has signs of cortical injury, that means the chances of this patient having large vessel occlusion is very high. So we need to know this. Neglect, aphasia, field cut, gaze preference, or dense hemiparesis. We talked about the target timelines according to American Heart Association. So the first 10 minutes, the ER physician assesses the patients. Within 15 minutes, the patient should be seen by a neurologist. By minute 25, CT scan should be done, read, and if the decision was made to give TPA, then TPA should be given by 30 minutes. So get the patient out of the scanner, give the bolus, start the infusion, get the patient back in the scanner, and do the CTA. I know some centers, they want to save time from their own perspective. They do CT angio, and then decide to give TPA or not. But this is ideally not correct. So you do the CT scan, you get the patient out. If the CT scan showed no bleeding, no contraindication to TPA, then you give TPA, put the patient back in the scanner to do the CT angio. Okay? So after the CT angio is done, if there's large vessel occlusion, then if your hospital provide the service of mechanical thrombectomy, then patient should be transferred immediately to the angio suite. Or if the hospital does not have that service, then patient should be transferred as a life-saving for mechanical thrombectomy. One of the main questions when you interview patient with acute strokes is time of onset, because based on these questions, decision-making and treatment can change. So you got to make sure that you have a very clear time of onset. Sometimes it's hard to pinpoint, but you can do your best to make sure when was the last time the patient seen well. والله المريض نام الساعة 10 وصحي الساعة 5 تعبان. طب هو when he went to bed at 10 p.m. was he normal or he was having mild symptoms? Very important. He went to bed at 3, woke up at 5 with symptoms. But he woke up normal, then he had symptoms, or he actually woke up with symptoms. It makes a huge difference in terms of management. So one of the main questions that we should be focusing on, actually, this is what I ask the residents or the ER docs when they call me. The most important question is, when was the last time the patient seen well? Because if the patient is the answer of the patients, put him within the window for acute treatment, then I can start thinking seriously about it. But if you say, well, the patient had symptoms like 2 days ago or 3 days ago, it's kind of too late. But as long as the patient was within 24 hours, then you got to take the patient seriously. Confirm medical history. So in addition to stroke symptoms, medical history, review of medications, comorbid and functional status before the strokes. So past medical history is always helpful to justify the mechanism of the stroke. So if the patient comes in with a stroke and he's in AFib, you would assume that this is probably because of cardioembolic cause. History of hypertension, diabetes, smoking also can be a cause of small vessel disease. So past medical history is important, not in the acute sense, but it's good to know about past medical history. We talked about this. Like, this is a very important note. So upon assessing patient with strokes in the ER, there's a common language that we use as neurologists. We use this score, the NIH stroke scale. So it's a quantitative scale that tells me how severe this is the stroke. But you can only use it if the patient has stroke. Because if you do this in patient with sepsis who is unconscious, he'll get high score, and you could say he has a very, very severe stroke, which is not true. You only can use this score in case the patient has clinical stroke. If the patient has clinical strokes and you use this, it's very helpful language. So if you call me over the phone and say, I have a patient with acute stroke with the NIH stroke scale 15 or 20, you got my attention. Even if I'm asleep, I'm up now, I'm awake. Why? Because patient with acute strokes, the higher the score, the likelihood of this patient having large vessel occlusion is very high. So if the score is above 10, the chances the patient has large vessel occlusion is probably greater than 80%. When the NIH stroke scale is less than 8 or 6, then you're dealing with an acute stroke, but probably, less likely, you're dealing with large vessel occlusion. There are always exceptions to what I just said. Always. I'm talking about the common scenario. Higher score, more likely large vessel occlusion. Lower score, less than 6 or 8, then it's likely not a large vessel occlusion. However, there are exceptions. But you get my attention when you say the stroke scale is above 10. So it's very good to get nursing staff, ER staff, ICU staff, ICU nursing to get trained. It's a neurologic exam basically, and the training will be on how to score your findings. That's all. Yeah, I mean, we're not doing something unusual. It's a neurologic exam. The training is about how to score points for each exam findings you have or you see when you upon your examination. Right. What basic blood work you send when you approach patient with acute strokes? It's the basic blood work. CBC, electrolytes, renal function, liver function, coags, whether the patient is on treatment or not, troponins and type and screen. When in regards to stroke imaging, we need it for multiple reasons. Well, number one is to diagnose. This is ischemic stroke versus hemorrhagic. Then, if this is ischemic, do you see an ischemic changes already happening in the CT scan? 3, do you see any hyperdense clots on the non-contrast CT scan? Because sometimes you can see on the non-contrast CT scan clots in the MCA or the basilar or carotid. Then CT angio is basically to rule out or to rule in large vessel occlusion, intracranial atherosclerotic disease, and so or dissections or so forth. So CT and CT angio helps me in decision making, whether I should be giving TPA or should we proceed with mechanical thrombectomy. If you could see here, so this is a non-contrast CT scan showing, if you look at the area here, early ischemic changes, where you lose the gray-white matter differentiation. Same here. If you could see the insula here, you can see the distinction, right? But here it's kind of mushy and you don't see it. Same thing here. You can see the ridges of the insula, but you don't see it here. Same thing here compared to here. You see the gyri very clear, but you don't here. And because of the loss of differentiation and the swelling. Same thing here and here. And this is also the non-contrast CT scan showing hyperdense clot in the MCA on the left. Same thing here. The right side, right M2 branch in the Sylvian fissure. So all this is from the non-contrast CT scan. CT angio basically can show you a big filling defect in one of the blood vessels. And this is the middle cerebral artery on the left side. Same thing here. Right, we were talking about the benefit of TPA. This is just to give you an example. When you treat patients, I don't know if this is clear, but when you treat patients within 3 hours, right, if you treat 100 patients within 0 to 3 hours of symptoms onset, you get 32 patients improving. So 1/3 of patients improves. But if you waited for the last 1.5 hours, half of these patients improve. So you basically, your improvement rate drops significantly just because of 1 hour delay from 3 to 4.5 hours. So the number needed to treat is 3 to 7, and this varies depending on the time of TPA administrations. If you administer TPA early on, your number needed to treat is less. If you administer TPA late within the window, your number needed to treat goes up. So the dose of alteplase is 0.9 milligram per kg, and you give 10% of this dose as a bolus, and then the remaining 90% of the dose as an infusion over 1 hour. Currently, we only have alteplase. Tenecteplase is probably coming to replace alteplase, but as of now, we only have alteplase. One thing is, when you have a patient who you think he or she is a candidate for acute stroke treatment, meaning TPA, you speak to the pharmacist to mix TPA immediately, because to mix this takes probably 10 minutes. You don't want to lose 10 minutes mixing TPA. If you think this patient is a candidate, mix TPA and then decide whether you should give or not. My understanding is that the company actually replaces, at least this is what I know from before. The company replaces the pre-mixed TPA if it wasn't given. Some people say, well, it's expensive. I don't want to mix it if you're not going to give it. But I know that the company can replace it if you pre-mix it but didn't give it. So what are the indications of TPA? So stroke symptoms, onset within 4.5 hours, disabling deficits, CT scan does not show any hemorrhage, and the age is above 18. Exclusion criteria, I have a long list of TPA contraindication, but just to make it easy, any condition that predisposes patients to hemorrhage is a contraindication, whether it's low platelets, high INR, patients on anticoagulation, or there's a recent surgery, or any history of brain hemorrhage in the past, or surgical intervention is a contraindication. This is the long list of contraindication. You can look at it later if you want. In regards to nursing, so I know this is an issue, because when I say one-to-one nursing care, people are gonna laugh at us. But ideally, these patients, if the patient receives TPA, should be monitored in an ICU setting, 1-to-2, 1-to-1, but at least in a semi-ICU settings, because these patients need, in the first hour, Q15 minutes neurochecks, and then Q30 minutes for another hour, and then Q1 hour neurochecks for another for 24 hours. So you want to keep the patient under observation for the first 24 hours. After 24 hours, you can move the patient to the regular floor. It's okay. It's the first 24 hours because of the expected complication. And the main two complications that people are afraid of with TPA is hemorrhage, whether it's intracranial or extracranial. Number two is allergy in the form of angioedema. So that's why patient needs to be monitored. Another point, if the patient received TPA, I know nursing staff always talk about this with the physicians. Oh, we would like to insert Foley catheter. We want to put NG tube. We want to insert cannulas. We want to do this and that. I mean, this should have been done early on before TPA was given. If you think patient needs NGT or Foley catheter immediately, then this should be administered before the TPA. But if you think this could wait, then wait after 24 or 48 hours before you put the Foley or nasogastric tube. Usually we refrain from giving antiplatelets or anticoagulation in the first 24 hours. And after 24 hours, if the patient is stable clinically, CT scan showing no hemorrhage, you can put the patient on antiplatelets or anticoagulation depending on the indication. This is one of the very rare but expected complication with TPA, which is angioedema. And you can treat this with ranitidine or antihistamine or steroids. But you got to keep it in mind because patient usually, you got to understand, sometimes patients start to slur their words and people think that, oh, he's deteriorating neurologically because he's dysarthric now, but it's actually angioedema. So you always have to look at the tongue, make sure that there's no angioedema, if the breathing is intact, because this is something of a concern. Sometimes it's so severe that patient cannot breathe. So you got to be very proactive. The last two slides is about endovascular treatment. So endovascular treatment was approved in 2015, and it changed the history of the game because, as I was saying, stroke management, and people actually lost hope for stroke long time ago, and they thought there's nothing to be done. The brain tissues are very sensitive to ischemia, and the longer you wait, there's nothing to be done. But in 2015, it was a revolution. We knew from multiple trials that actually the number needed to treat varies between 1 in 3 and 1 in 5. 1 in 3 patients actually can come back to normal. So you have a patient who comes in with aphasia and right-sided weakness, gaze deviation. They can come out walking. So this is very important. You have to know that the faster you act, the more proactive we are, we can actually deliver the best care and give the patient the best chance of recovering. You have to understand, not every stroke patient is 70 or 80 years old. I've seen stroke patients who are 30. I've seen stroke patients who are 35, 40. They're young. So I know that some people have this impression, oh, this guy is 90 years old. I mean, you can leave him in peace. You can just, don't torture him. But unfortunately, we see young patients with acute strokes and large vessel occlusion who you can change their fate. You can actually bring them back to life. So always keep in mind that acute stroke treatment is changed. And according to the Vision 2030, acute stroke treatment is actually one of the main points in the agenda to achieve, is to have acute stroke centers in each region. And we're going to collaborate to establish stroke protocols. But before this happened, we need to be proactive, starting from now, actually. To deliver, it's interesting because we have this treatment. It's not like we're delivering chemotherapy of some sort of rare cancer or something. This is a standard of care, and we have it. We can give TPA, and King Abdullah Medical Complex is like a few blocks away from us. We can send the patient immediately to receive thrombectomy. I don't want to talk about the mechanism, but there are two ways of the clot. One is using stent, which you can see here. So this is basically a stent. You can put it in a catheter, go all the way up to the occluded artery, deploy the stent. So what happened is the clot gets intermingled within the stents, leave the stent for a few minutes, and then pull it out. So the stent actually pulls the clot out. So that's one technique. The other technique is using a big catheter and use it as a vacuum to suck the clot. So there are two techniques, and both are effective. It doesn't matter which one you use. It doesn't matter your center, which one, as long as they can offer mechanical thrombectomy, use whatever technique you want, as long as you achieve a reperfusion as soon as possible. This is the last slide. I want to emphasize that door to needle for TPA is 30 minutes. Door to needle for thrombectomy is 60 minutes. And you have to understand that the only way to achieve this is by working as a team from the get-go. Once the patient hits the ER door till patient receives treatment. If we don't work in harmony together, we cannot meet those timelines. Thank you.
خلاص وصلنا الحمد لله نهاية اليوم. نشكر لكم حضوركم، شكرا لكم جميعا. بكرة ننتظركم إن شاء الله الصباح من الساعة 8 بإذن الله. راح تبدأ محاضراتنا على الزوم متزامنا مع المحاضرات الحضورية. شكرا لكم، يعطيكم ألف عافية من حضوركم.
In our perspective. So when you think
إذا حابين تستفيدوا ممكن تنتظروا تسمعون.
like protocol really will have a knowledge who can convince himself of symptoms and will not wait for 2-3 days biopsy.
So I'm going to repeat the question. The question was, you had 2 incidents, you had 2 incidents of 3 strokes, you had all the struggling to respond to the manufacturing. We're not sure the food is not included with the stroke. But this is, inshallah, is going to change soon because we're going to, so this is going to be a project where KPI should be met. And cases like these are not going to go under the radar. People are going to be like, okay, so this patient presented with acute stroke symptoms, nothing happened. Why? So hopefully with this project, we're going to keep track of all patients with acute stroke symptoms within 24 hours and see what happens. Because if there's mismanagement, we need to fix it. Definitely. Inshallah.
Why I'm asking, because when I was in national guard, I had one patient, inpatient, he had a good stroke. In 30 minutes, he had TBA with 100%. And he was discharged, fully conscious, 0 symptoms. Here, it's the other way around.
Let's say baby steps. National Guard have been doing this for a while now. And I worked for a year almost. So I know that they've been doing this for a long time. Here, it's a different story. We're just starting. So to implement the change. So the hardest thing, well, probably you know, that when you start a new project, it's not the material, it's not the resources that actually hasten the movement of the project. It's the mindset change. Exactly. When you get the people on the same page, then things are going to move forward. Resources, materials, plans, then do not change anything. Exactly. So it's the mindset. If you get the people on board, if you get the people convinced, and I say this all the time. I say, we live here, our family can visit here, right? I mean, God forbid, we have people who are related to us, we have people who are dear to us, who can visit the hospital. And they can have a stroke, but if we don't have a good program, they're going to be affected. So I say that all the time. So, inshallah, soon enough, change will happen. But we're working on changing the mindsets first.
Thank you so much. That was very informative, very nice. Just waiting for implementation. Very
soon enough.
إن شاء الله. Thank you, دكتور. يعطيك العافية. شكرا لك. Thank you for all of you. We finished our day, our lecture. Tomorrow, inshallah, we'll see you.